Lakini kuna ile ambao umekaa na ambao unajua venye nafanya kazi. So kile ambacho hatujaona kikifanya kazi, wacha tukiekee 40% for now. Kile naweza sema watoe wasitoe. Kama wamepanga, kama wako na mikakati ambayo haitakuwa kama ile ya kitambo ni sawa. Lakini kama wataenda na ile sheria na ile mikakati ambayo walikuwa nayo haitafanya kazi. Sasa ina venye kuko. Kuna economy itachange ama ni yenye iko. Kuko sasa bro. Chenye kidogo unapatwa. Sawa? Unakatwa pesa zako unapata hauna kitu. So ukiniambia ukate mwananchi pesa. Unaona? Ili to remain tuna chenye tulikuwa tumezoea basi. Hata kama tutakuwa tunalipa na tusaidiki. Unajua hakuna haja uingie kwa mifuko ya watu ambao hawana pesa.
This is a system of the American which they're trying to push now to Kenyans, and I don't think it actually is going to work on us. The universal health system is an ideology of the Americans. So I think as the African people and even the Kenyans, we need to come up with our own way that is actually working for us. So these people, they're looking for a way to reap money, from us, while, masquerading at the name of, health system. But honestly speaking, what they're looking for is to enslave us in the name of health.
Lazima wa publicize hizi vitu. Lazima watume watu mashinani, wakuje waelezee watu, tupate kujua na kufahamu. Otherwise, if they do things in the office, na sisi huku mashinani hatujui, then we can't trust. Wakati tutaenda tuambiwa, we can't trust them. Tutaona kama ni kitu fishi.
It's the time now our government iamke na ikuwe serious, because I wish tu kuna wakubwa wangekuwa wanatumwa kwa hizo OC, ama mtu atume mtu wake mkubwa mmoja tu kwa hiyo serikali, atume mtu mmoja wa kwake ama wa kwao ambaye ni mgonjwa, because sioni venye mtoto anaweza fariki akiwa ameshikiliwa, because unajua ukienda na mtoto ama mtu amezidiwa kwa private atahudumiwa yeye mwenyewe, lakini kwa government mtu anaweza kufa kwa line. So ni wakati our government iamke kama inataka Kenya inuke, na kama inataka Wakenya waheshimu OC za government, unaona, because
NHIF na ukienda public pia utapata ndawa na hiyo NHIF umeilipia.
Mimi ulipa NHIF lakini mimi wasiendi kwa OC ya government.
NHIF tunalipa, lakini unakuta mara nyingi haikavi, pengine ile hospitali umechagua haikavi ile unataka.
I used to pay NHIF, but the efficiency of NHIF iliniangusha. So kama si efficient bado na pay, napata uko na NHIF, kuna usiwezi enda, kuna vitu wezi kata, so the best afadhali niende to private.
Me, I love private hospital because ukienda pale watakundumia haraka, na hakuna haja nienda kwa OC ya gava and then the same people watanituma kwa ninunue madawa nje, and that means wako kwa government but wanafanya biashara nje, because wanakuanga na ile chemistry yenye utatumwa, si kila chemistry wanakuandikia hapo. So wacha niende kwa OC, uenda private wanihudumie kwa upole, na kuna chemistry yao hapo, hawatanituma mahali na nitakuwa sawa.
Nikiwa mgonjwa, mi most of the times nabaingi tu dawa kwa chemist most of the times, juu inakuanga actually ni cheaper. So watu wanaenda most public hospitals, although haziko fully equipped ama haziko resources zake haziko totally good, unaona, but watu wakizidiwa most of the time siku hizi they go just to public hospitals.
Mimi naendanga private hospital sababu hapo utapata huduma ya haraka na mandawa iko, lakini public ukienda unaweza shinda huko na baadaye ukose ndawa ama hata ukose kuhudumiwa.
Their services are good nowadays. Kitambo madaktari walikuanga rude, but nowadays the nurses that we meet they are okay. Mimi kulingana mahali huwa ninaenda, I can say there is a great change. Wale nurses tunapata sahi, they are friendly, they are good. Hata wanapokuambia uende ukanunue madawa, hawakufukuzi, wanakuelezea vizuri na understand.
sijasikia anything about SHIF. Taxing inafanywa hadi kwa wenye hawana nini, wako jobless bado wanataksiwa. So unaona, society wanatufanyia favor. Hii ni kama demand tu, ni kitu lazima ifanyike, na sioni kama ita-implementiwa vile inasema tutasupportiwa fully. There is no full support because tuko sure hakuna kitu bure. You cannot get anywhere service for free.
SHIF haita change, wacha niweke for now, wacha cause ni kitu ambacho hatuja experience. Unajua hauwezi ukakataa kitu hujaona venye nafanya kazi, lakini kuna ile ambayo umekaa na ambayo unajua venye nafanya kazi. So kile ambacho hatujaona kikifanya kazi, wacha tukiwekee 40% for now. Kile naweza sema watoe wasitoe, kama wamepanga, kama wako na mikakati ambayo haitakuwa kama ile ya kitambo ni sawa, lakini kama wataenda na ile sheria na ile mikakati ambayo walikuwa nayo haitafanya kazi. Sasa ina venye kuna economy itachange ama ni yenye iko huko sasa bro, chenye kidogo unapatwa sawa, unakatwa pesa zako unapata hauna kitu. So ukiniambia ukate mwananchi pesa, unaona, ili to remain tuna chenye tulikuwa tumezoea, basi hata kama tutakuwa tunalipa na tusaidiki, unajua hakuna haja uingie kwa mifuko ya watu ambao hawana pesa.
This is a system of the American which they're trying to push now to Kenyans, and I don't think it actually is going to work on us. The universal health system is an ideology of the Americans. So I think as the African people and even the Kenyans, we need to come up with our own way that is actually working for us. So these people are looking for a way to reap money, from us, while, masquerading at the name of, health system. But honestly speaking, what they're looking for is to enslave us in the name of health.
Lazima wa publicize hizi vitu, lazima watume watu mashinani wakuje waelezee watu tupate kujua na kufahamu. Otherwise, if they do things in the office na sisi huku mashinani hatujui, then we can't trust. Wakati tutaenda tuambiwa we can't trust them, tutaona kitu fishy.
It's the time now our government iamke na ikuwe serious, because I wish kuna wakubwa wangekuwa wanatuma kwa hizo OC, ama mtu atume mtu wake mkubwa mmoja tu kwa hiyo serikali, atume mtu mmoja wa kwake ama wa kwao ambaye ni mgonjwa, because sioni venye mtoto anaweza fariki akiwa ameshikiliwa. Because unajua ukienda na mtoto ama mtu amezidiwa kwa private atahudumiwa yeye mwenyewe, lakini kwa government mtu anaweza kufa kwa line. So ni wakati our government iamke, kama inataka Kenya inuke na kama inataka Wakenya waheshimu OC za government, unaona, because unapata pale zile vitu unapata hazipo.
It starts from the management. If the management is poor, no matter what exactly you're trying to implement, whether it's medication, they're not going to be there. So right now we are facing the issues of implementation of drugs and so on, that can be able now to cure people in the hospitals. But because of poor management, all these things are not filling now to the public. So I think the government need to put the right people whom their main intention is to serve mwananchi, the poor mwananchi, but not just only their stomach. There are a lot of people who, like, when these medicines also come there, which is actually an aid which need to serve people freely, but then they're taking to their private hospitals and start selling. I'm not saying that I have evidence of this, but this is what is happening in Africa as a whole. Some people want to benefit on behind of ignorant people who doesn't know what is going on.
If on their side they do what they are supposed to do, employing enough staffs, giving medical, and making sure that their facilities are well equipped, then we shall trust them in so many things. Because if we cannot trust them in health, even in other things, we cannot trust.
I don't have NHIF, but because the NHIF, I'm just being honest with you, I believe in the implementation of the government, but when it comes to HIF, it's a bit shoddy, so I don't associate myself with them.
Mimi sina NHIF, sina hiyo do kabisa. Hata sijui tutachukua nini by the.
NHIF nilikuwa nailipa, but for now wasilipi. Juu hata private mingi azitumie NHIF, na ukienda public pia utapata ndawa na hiyo NHIF umeilipia.
Mi ulipa NHIF lakini mi wasiendi kwa OC ya gava.
NHIF tunalipa, lakini unakuta mara nyingi haikavi, pengine ile hospitali umechagua haikavi ile unataka.
I used to pay NHIF but the efficiency of NHIF iliniangusha. So juu kama si efficient bado na pay napata uko na NHIF kuna usiwezi enda, kuna vitu wezi kata, so the best afadhali niende to private.
Me, I love a private hospital because ukienda pale watakundumia haraka na hakuna haja nienda kwa OC ya gava and then the same people watanituma kwa ninunue mandawa nje, and that means wako kwa government but wanafanya biashara nje because wanakuanga na ile chemistry yenye utatumwa, si kila chemist wanakuandikia hapo. So acha niende kwa OC, uenda private wanihudumie kwa upole na kuna chemistry yao hapo, hawatanituma mahali na nitakuwa sawa.
Nikiwa mgonjwa mi most of the times nabaingi tu dawa kwa nini, kwa chemist most of the times juu inakuanga actually ni cheaper, so watu wanaenda most public hospitals although haziko fully equipped ama haziko resources zake haziko totally good, unaona, but watu wakizidiwa most of the time siku hizi they go just to public hospitals.
Mi naendanga wa private hospital sababu hapo utapata huduma ya haraka na mandawa iko, lakini public ukienda unaweza shinda huko na baadaye ukose ndawa ama hata ukose kuhudumiwa.
Their services are good. Nowadays, kitambo madaktari walikuanga rude, but nowadays the nurses that we meet they are okay. Mie kulingana mahali huwa ninaenda, I can say there is a great change. Wale nurses tunapata sahi, they are friendly, they are good. Hata wanapokuambia uende ukanunue madawa, hawakufukuzi, wanakuelezea vizuri na understand.
Sijasikia anything about SHIF. Taxing inafanyiwa hadi kwa wenye hawana nini, wako jobless bado wanataksiwa, so unaona society wanatufanyia favor. Hii ni kama demand tu, ni kitu lazima ifanyike, na sioni kama ita-implementiwa vile inasema iti tutasupportiwa fully. There is no full support because tuko sure hakuna kitu bure, you cannot get anywhere service for free.
SHIF haita change, wacha niweke for now, acha cause ni kitu ambacho hatuja experience. Unajua hauwezi ukakataa kitu hujaona venye inafanya kazi, lakini kuna ile ambayo umekaa na ambayo unajua venye inafanya kazi. So kile ambacho hatujaona kikifanya kazi, wacha tukiekee 40% for now. Kile naweza sema watoe wasitoe, kama wamepanga, kama wako na mikakati ambayo haitakuwa kama ile ya kitambo ni sawa, lakini kama wataenda na ile sheria na ile mikakati ambayo walikuwa nayo haitafanya kazi. Sasa ina venye kuna economy itachange ama ni yenye iko huko sasa bro, chenye kidogo unapatwa sawa, unakatwa pesa zako unapata hauna kitu. So ukiniambia ukate mwananchi pesa, unaona ili to remain tuna chenye tulikuwa tumezoea, basi hata kama tutakuwa tunalipa na tusaidiki, unajua hakuna haja uingie kwa mifuko ya watu ambao hawana pesa.
This is a system of the American which they're trying to push now to Kenyans, and I don't think it actually is going to work on us. The universal health system is an ideology of the Americans. So I think as the African people and even the Kenyans, we need to come up with our own way that is actually working for us. So these people, they're looking for a way to reap money, from us, while, masquerading at the name of, health system. But honestly speaking, what they're looking for is to enslave us in the name of health.
Lazima wa publicize hizi vitu, lazima watume watu mashinani wakuje waelezee watu tupate kujua na kufahamu. Otherwise if they do things in the office na sisi huku mashinani hatujui, then we can't trust. Wakati tutaenda tuambiwa we can't trust them, tutaona kama ni kitu fishi.
It's the time now our government iamke na ikuwe serious, because I wish tu kuna wakubwa wangekuwa wanatuma kwa hizo OC. ama mtu atume mtu wake mkubwa mmoja tu kwa hiyo serikali, atume mtu mmoja wa kwake ama wa kwao ambaye ni mgonjwa, because sioni venye mtoto anaweza fariki akiwa ameshikiliwa. Because unajua ukienda na mtoto ama mtu amezidiwa kwa private atahudumiwa yeye mwenyewe, lakini kwa government mtu anaweza kufa kwa line. So ni wakati our government iamke, kama inataka Kenya inuke na kama inataka Wakenya waheshimu ofisi za government, unaona, because unapata pale zile vitu unapata hazipo.
It starts from the management. If the management is poor, no matter what exactly you're trying to implement, whether it's medication, they're not going to be there. So right now we are facing the issues of, implementation of drugs and so on, that can be able now to cure people in the hospitals. But because of poor management,
morning,
all these
everyone.
things are not filling now to the
Good
public.
morning,
So I
people.
think the government needs.
How are we doing? Thank you so much for being patient with us. Now we are ready to begin, but we need to have some ground rules first. So I want to invite Mr. Tom. Mr. Tom works with Pakin, the facility that is hosting us today. He'll give us a bit of security details and housekeeping before we can get into the thing that has brought us here. Thank you so much and good morning.
Good morning, ladies and gentlemen. My name is Tom. I'm the hotel security supervisor in charge of operations for this beautiful hotel. Can allow me to welcome you to Pakin by Radisson. Pakin is just a brand within the Radisson Hotel family, and this lovely hotel is located in Westlands. It's a 5 kilometers drive in Nairobi CBD and 22 kilometers drive from the Jomo Kenyatta International Airport. At Pakin by Radisson, we enjoy serving with the kind spirit, and every moment matters for our guests. This hotel is guarded by 3 teams 24/7. I'm sure when you are getting in this morning, you met some men and women in black suits at the main gate. Part of the team is deployed at the lobby area, and the rest of the team is deployed at the basement parkings. For information, the hotel has 3 basement parkings. The second team is the Kenya police officers from the Kilelesha police station. This team is on the ground as I speak by now. And the last team is the hotel team. Now, when the alarm goes off, that means in case of an emergency, the instructions will be given to you through the public address system. That means you'll have to leave the room politely and use the stairway at the coffee serving area as we exit the hotel. Our fire assembly point is outside the hotel, direct opposite the hotel main gate. This hotel has first aiders and fire marshals, and these teams are trained to assist you. Remember also the lifts will be grounded. You'll not be allowed to use the lifts. And while at the assembly also, you'll not be allowed to leave the assembly because there will be a communication from the incident commander. In this case, the hotel general manager who does it. The communication is simple, that all areas will have been cleared. Now you'll be allowed to resume back to normal. This floor is called meeting and events, mezzanine 2. It has washrooms, serving ladies and gents just behind the coffee serving station. And in case of any medical emergencies, we normally advise our clients to seek services from the Mpisha Hospital, which is 5 kilometers away from us. The hospital is in Parklands, right? We will take your lunch at the hotel main restaurant. This is the Levin restaurant at the ground floor. Kindly get to know the person sitting next to you, and if you see something, you may say something, right? Also, I'll share with you our 2 numbers. These numbers must assist you in case of any security challenges during your stay with us, please. If you don't mind, you can have the numbers with you. The first number is for the hotel security manager. The hotel security manager is Mr. Charles Mwangi at 0795 740 751. I'll repeat. The hotel security manager is Mr. Charles Mwangi at 0795 740 751. The second number is mine. My name is Tom. Tom at 0797 00 5590. I'll repeat. My name is Tom at 0797 00 5590. I wish you all the best as you engage amongst yourselves. May God bless you all. God bless Pakin. God bless our lovely Kenya. Thank you so much. Thank you, Sarah.
That was important so that we all feel safe. Thank you, Mr. Tom, and thank you, Pakin, for hosting us. A bit of housekeeping, please. If you have not grabbed a cup of coffee, the coffee is being served outside. Please do, but we'll also have another coffee break later on. And then something else, we have, yes, this venue here, and those of us who are in this room, but this conversation is also on Zoom. So allow me to check with my colleague Jane. Jane Schuster, if you can hear me on Zoom, please confirm that you can hear both and see us as well. Jane?
Good morning, Sarah. We can hear you, but you're very faint, so maybe you can speak up a little bit more.
Oh, okay. So we'll get to work on that. That said, the washrooms are outside, and then you'll walk straight to where the coffee area is, and then just there's the ladies, and then there's the gents. But we are ready to begin now. I would like to request that the technical team sets the national anthem, and then the rest of us can be upstanding for the national anthem. Gilbert, when you're ready, we are.
Mungu nguvu yetu, ilete baraka kwetu, haki iwe ngao na mlinzi, na tukae na udugu, amani na uhuru, na tupate na ustawi.
Thank you so much for that. Now we are ready to begin. But if you have a colleague, a friend outside of this room and out of Zoom, please send them a link of this conversation. Let them know that they can join in and share that link. Social media, the conversation is happening and we're using hashtag #SauTizOnanchi or hashtag #AfriaNA2. And please remember at @TwawezKE on Twitter. Thank you so much. Now we are ready to begin the conversation, but we have to understand who the hosts are. So to help us understand who has organized this event and what the organization is all about, I would like to welcome Josiah Wandera, a colleague at the Kenyan office, to just tell us about what this is about, what tourism is about, and why this is important. Josiah Wandera, please.
Thank you, Sarah. Good morning, everyone. Thank you so much for making time to join us today. So I've been given about 20 minutes to tell you about Twaweza. This means I have 20 minutes to tell you why I wake up every morning to come to work, though I mostly work from home. So who is Twaweza? We are a global organization, but grounded in East Africa. But why do we exist? And to tell you a little bit about that, I think it's important that we refresh our minds about the current state of things. So number one, we are living in an increasingly turbulent world. So, fragile economies. We had COVID-19, we had the wars in Ukraine and the Middle East, increasing inequalities, the rich continuing being richer, the poor poorer. Climate crisis is no longer a future threat. It's here with us now. Democracy is under attack. Authoritarian governments and leaders are becoming more confident day by day. And number two, we have citizens and governments who have very fragile relationships. In East Africa, for example, for decades, governments have expected obedience from citizens, rather than being guided by the need to recognize and respond to our interests and priorities. And as a result of that, citizens have learned to expect less from their governments. And they have normalized that we will have to share with you. Two, intentional organizing, bringing people and organizations together, to discuss critical societal issues. And I think that's also the reason we are here today. We also would love to keep, forming equitable partnerships with people who are working towards addressing the same problems as we are. Empathetic engagements, and this is very key in our new strategy, because we want to speak to the motivations and the barriers of those we seek to persuade. So if we are persuading people in government, we actually want to understand what makes them work the way they do, what constraints are they facing, and how can we help. So we want to have that level of empathy when we're engaging with people we want to persuade. The final piece, which is very critical still, is telling compelling stories. And that's why I think the media are very critical for us in amplifying our research findings and the stories that we gather from the various interactions that we have. So that is it about weather. You can read more about our current strategy on our website. But I wish us all a fruitful discussion, and I hope you can come out of here, with one or two new things. Thank you so much. Back to you, Sarah.
Shall we give Josh a round of applause? Thank you so much, Josiah, for that brief about what Torres is all about and why we exist. That's very important. Thank you so much. Now, we are trying to get connected back to the virtual audience, but as we do that, I'd like to welcome us to engage with us, for example. Would you, as we get that sorted out, allow us to hear from you, first of all. Let us know where you're coming from. Please, just your name and which organization you represent. Can we keep it that brief, please? Yes. That's very important as we get sorted on the technical issues. We'll start with you, Beatty. Let us know what your name, please, strictly, and the organization you represent, and why this is important, why it's important that you're here.
Good morning.
Good morning.
Good morning. Betty Kimani is my name, from Kiambu County, Kikuyu constituency, Kikuyu ward. I am representing an organization by the name Bunge Mashinani and Bunge Mashinani School of Governance. It is located in Kiambu County, Kiamba Sub-County, Karuri Ward. My intention for being here today is that coming from an organization that is dealing with the civic space, it interests me to see how we can partner and improve the level of citizen engagement so that we can be able to steer where we can forward.
Good morning, everyone. I'm Julius Waome. I work with Bunge Mashinani. I'm from Kiambu County.
A round of applause for Julius, please. Thank you so much, Bunge Mashinani. Please give it to your name, the organization you represent, and why you're here, please.
Hi, my name is Jeremy Mutunga. I'm from County Assemblies Forum, and I'm here just to see everyone's views on the topic and to share experiences.
Thank you so much, Jeremy. Thank you for representing the CAF.
Good morning. I'm Sophia Ngige, working with Peaceful Change Initiative. Why I'm here is I think health is very important, and it's good to hear, is there something we can do even before this is rolled out soon?
Okay. Thank you so much, Sophia. It's wonderful to have you.
Good morning, everyone.
Good morning.
My name is George Awala, and I work with VSO. We have an interest in health, education, and livelihoods, especially for young people, women, and persons with disabilities. Why this is important to me is we work a lot with persons with disabilities and women. So I'd like to see what does SHIF mean for these groups of individuals, and is there something that's specific for persons with disabilities, and how will that play out? And what do the citizens think about what the government is proposing? Shukran.
Thank you. Really appreciate for you being here.
Good morning, everybody. My name is Chris from NTA. I am here to learn, to see what I can input in this project, and also to learn from everybody here. Thank you.
Thank you so much, representative of NTA.
Morning, everyone.
Good morning.
My name is Oginda Joshua. I'm from NTA. Come to hear about the Social Health Insurance Fund.
Thank you for being here.
Morning, everyone. My name is Zilpa. I'm a health economist from the London School of Economics. I'm researching health financing reform. That's why I'm here today with you guys. Thank you.
Thank you so much, Zilpa.
Good morning, everyone.
Good morning.
Good morning, everyone.
Good morning.
Thank you. My name is Wanjiru Kenywa. I come from an organization called Crown Trust. Crown Trust is an acronym for the Community Advocacy and Awareness Trust. We deal with issues to do with women and girls. So the reason why I'm here is we've been getting a lot of questions from our women. What is this SHIF? Why do we even have to move to it? So that is why I'm here to get more information so that you're able to reply to all those questions.
Thank you so much.
Good morning, everyone.
Good morning.
My name is Dorcas. I'm from Machakos County. I work with an organization called Mane Kenya. And Mane works with community. So why I'm here today, I want to know how the SHIF will benefit the local woman at Kitui, at Machakos County. Yeah, and the difference between NHIF and SHIF. Yeah, thank you so much.
Difference between NHIF and SHIF. Thank you for being here.
Good morning, everyone.
Good morning.
I'm Achieng Joan from Inuka Kenya Nisisi. So I'm here today to learn more about SHIF, and also we normally amplify the voices of the common mwananchi. So I'm here to learn and also amplify.
Thank you so much.
Hi, morning, everyone. My name is Susan Jeru. I'm here on behalf of FIDA Kenya. We to be done as a civil society organization. Okay.
Thank you so much. Please, let's do it faster.
Good morning.
Good morning.
My name is Claire Amuyunzu. I work with African Institute for Health and Development. We work in the health space, and this is an opportunity for us to explore how we can impact people's health through SHIF. And personally, I also want to understand how SHIF is going to help me, because I also contribute. Thank you.
Thank you so much.
Good morning, everyone. My name is Kala Moabarra. I'm from GE Healthcare. I'm here to learn how the difference between NHIF and SHIF, because we are also working with government, private, NGOs in the health space. So that's why I'm here. Thank you.
Thank you so much. And now we hear from...
Good morning, everyone. My name is Christina Kinyi. I work at ICJ Kenya. The reason why I'm here is because ICJ works to promote human rights, including the right to health. We are currently implementing a project on right to health, where we are reviewing the legal framework, and we've identified gaps, and we'll now be pushing for reforms to ensure that all Kenyans enjoy their right to health.
Hi, everyone. My name is Marlene from Shamire Institute. It's an NGO that deals with mental health among the teenagers, more so in schools. And I'm here just to get to understand what SHIF is all about and how we can be able to integrate it in our organization. Yeah.
So allow us to take a break at that, and then we'll come to this side, at least so that we keep the room active and all of us involved. But that said, we are ready to get into the meat of the discussion. Melania Omongo will take us through the context and the reason why we're having this particular conversation today. So Melania is already going to the stage. Shall we give her a round of applause, please? Oops. Right, Melania, karibu sana.
being polite by telling the people on my right that they'll do it later because of monotony. I told her, you have to stop them. Otherwise, I will not have anything to say. Because the team on the left preempted most of the things which I wanted to say. Do not get worried. I am as confused and as clueless as you about the SHIF, how different is it to NHIF, and what are the different milestones, and the whole execution of the whole a new fund. So tuko pamoja, msiogope. So just quickly, before we even take a deep dive on our discussion today, we thought probably we could look back, say probably 10, 15 years on how our healthcare system has been. When the new constitution was enacted in 2010, two things happened. Well, of course it happened in a number of sectors, but two things in health sector happened. One, healthcare became a universal right to every single Kenyan. Not only access to healthcare, quality healthcare to every single Kenyan. Two, another very big reform is that healthcare reformed to the devolved unit. So those are two big measures. And the spirit behind this was to ensure that no Kenyan should die due to lack of healthcare. I think that was the big vision and the spirit behind this. And access should be easy, it should be fast. You know, if I'm feeling well, I can access any service less than even 100 meters from my home. And this can be manifested. You can see from the previous administration where we had quite a number of programs. We had Linda Mama. We had we have a program which focuses on the vulnerable, like the elderly, where they access service from public facility for free, expectant mothers and under 5. So there have been some element of activities or goodwill to show that the government has want to make it that every Kenyan have access to health service. Whether it's good quality or not, that is open to discussion. And I think in this current administration, they came up with the community health worker to even bring healthcare as low as it can get to the wananchi. Now, those are the various elements of looking at the general healthcare. And now looking to financing, because financing has been quite an issue. I mean, if you look at data 10, 15 years back, they seem to be a similar trend that we need affordable quality health care. Citizens are still saying we still can't afford this. I mean, it's really expensive. We have almost half of Kenyans saying we can't even access health care. From the Vox which were being played, you could see people are still either self-medicating, they're still not even seeking service altogether, and others even going to just the nearest shop to get when they're feeling unwell or when they're injured, which is not actually the intention of all this. I mean, we want every single person to be diagnosed, to go through all that process of healthcare. Currently, we had NHIF, as many mentioned when they're introducing themselves. And there are the goods and the pros and the cons of NIH are very clear. I mean, if you look again at data, they can clearly tell you that, well, at least I can get some service at some manageable cost. Many are saying that. And I think the statistics back then, I think in almost 2010, it said a third of people had mentioned, there's a survey we did, a third of people say that, you know, we have access to some kind of health insurance, and NHIF was the biggest. But of course, it has its own challenges. It has its own bottleneck. And the assumption which the current administration did put forward is the argument, what can we do to fill these gaps, the gaps which the health insurance aim to come in SHIF, which many of us We do not know how it is going to run, but I think two things come out from SHIF, from my understanding. I can be educated today, and I look forward to be educated and to be given more information. The aim is to ensure every single Kenyan have access to healthcare. And second, which to me I felt it's very interesting, that every single person will have to pay for it, regardless of their status, regardless of whether you are employed or not. So some money will have to come from your pocket to finance it. After that, I am not sure what is going on with that. And of course, I understand the goodwill and the good intention and the big vision of the SHIF, but a lot is yet to be discussed about, or us knowing about the SHIF itself. And we here, I mean, I think there was a Kenyan there mentioning she had a lot of interest. My namesake there, she's very interested in that. I don't know, I can't remember, I think Catherine for FIDA, a lot of interest on women. I had a gentleman mention that he has a lot of interest in disability, but none of them, they seem to be very lost on what the SHIF is all about. So our intention here today is to act as a springboard for that conversation of wanting to have more information. And Sarah has promised me that there are actually a number of experts here who might shed more light to us about that shift. What does it mean? Will SHIF come to address the gaps which Dr. Sierra here is going to share, the findings which we did early this year. So the idea was we wanted to see what is the current situation way before SHIFT is supposed to be commencing in July. Because SHIFT is supposed to commence in July, mark you, and we don't have any information. July is almost like 3 weeks ago. I'm saying at least it is 12 months to come. And so we thought, you know what, let's sense check what is happening right now in terms of how citizens access healthcare. What are the challenges which they face when they visit the healthcare to seek services, and then also to understand the current health insurance which they hold, and then subsequently to take a deep dive on the experiences and what is the good, the bad. The assumption is from this, then this can be a base of discussion on either improving SHIF or starting the conversation in detail of what SHIF is all about. So I think, Sarah, I will leave it there and welcome you probably to take us to the next course of action. There is much to say about the healthcare context, but for now I think I'll leave it for here. Asanteni sana.
Thank you so much, Melania. A round of applause for Melania Tafadhali. Thank you so much. And you know, the beauty about the people in the room is that many of them are experts in the health sector. And so I'm sure the nuances about health sector, its goods, its bad, its ugly, we are going to share in the next session. But now we need to proceed to why we are here, the reason why we invited you to come to this event. That is the presentation of the data, and that's going to be done by our country lead and senior data analyst, Dr. Sierra. So I would like to invite Dr. Sierra to come to the stage to take us into that session. Confirm to me that that is possible and that he can start sharing, because otherwise I'll proceed to let the team 2 introduce themselves. Gilbert, Jane, are we okay? All right, as we figure that out, allow me then to take this opportunity to continue. Philbert, please help me with that. Let's get the presentation going. Would you please introduce yourself, the organization, and why you're here?
Good morning. I'm Benedict Wakio Karaoke, a law student, but currently I'm an intern at Africa Youth Trust. So as an organization, we are here majorly to see what this change will do for the youth. And we also deal with a lot of women and children because of gender-based violence. We also want to see how we can actually explain the change to them and how it will affect them. Yes, thank you.
Good morning, everyone. My name is Marilyn Awar, working with Africa Youth Trust. We are here majorly to learn how actually the shift actually impacts us, working with the youth and in good governance, and also, as my colleague said, working with people from the gender-based violence group. Yeah, thank you so much.
Good morning. I'm Gabriel Mwai, representing Twaweza. We are here to learn more about the SHIF and the difference between the NHIF and the SHIF. Thanks.
Morning, everyone. I'm Joyce Ochieng. I'm a population health student, currently an attaché at Langata Health Center. I'm basically here to learn about SHIFT and how it will ensure equitable access for health for everyone.
Good morning. My name is Catherine Kigwai from Bunge Mashinani. I'm here to learn about the difference between NHIF and SHIF, the transition, what is going to happen. As a civic educator, I'll get more information. So when I go back to Mashinani, I'll be able to teach the community what is going on. Thank you.
Good morning, everyone. My name is Alex Musikoyo Odongo. I work with the Network for Research and Governance from Kakamega County. We deal with budget advocacy and policy at the county level. So I'm here so that we can be able to learn about the cost implications of this transition from NHIF to SHIF. Thank you very much.
Good morning, everyone. My name is Chebet Rispa. I work for an organization called Christian Aid Kenya. And our focus area is 4 key areas. That is peace building initiatives. We also do the reason I'm here is because of our month. Today I'll be very interested. Are we ready? And how ready are communities to the proposed SHIF? Thank you.
Thank you so much, Christian E. Thank you for being here. Let's hear from this table. And please signal me, Philbert, when you're ready. Okay.
Thank you. Good morning, everyone. My name is James Mogambi. I come from Laikipia County Government. I'm the Chief Executive Officer to an entity at the county government called Laikipia County Development Authority. Majorly at the county government, we try to look into how do we involve partners in various engagement. SHIF and NHIF, it's important to ask ourselves, how does different stakeholders and partners maybe dive into opportunities that are there in terms of making sure that the SHIF becomes a reality. Of course, analyzing the challenges that NHIF had, and of course, SHIF being a culmination to kind of a universal health coverage. How does different stakeholders and partners come on board to make sure that it kind of ensures that UHC is realized? Thank you so much.
Good morning. My name is Valerie Michelle. I'm working with CAS, which is Konrad Adenauer Foundation, a German political think tank. I'm here just to gain the different insights of everyone here and the experiences on the shift from NHIF to SHIF. Thank you.
Good morning, everyone. My name is Anne from Rwaka Bunge Mashinani Initiative. My main agenda is to learn more and to come out with something that I can help the community there.
Good morning, everyone. My name is Tony Kariri. I work for an NGO called Partners for Health and Development in Africa. Our focus area is mainly HIV prevention, treatment, and care. We serve key and vulnerable populations. These are populations which are at a high risk of HIV acquisition. We provide health services in Nairobi. We have different facilities. Why I'm here is we are keen to see and to know how will this impact on our service delivery, especially for the key and vulnerable population. I'm also a member of Transform Health Kenya Coalition, which is a coalition advocating for adoption of digital health to achieve universal health care. So we're also keen because this act came along with the Digital Health Act. We have the Data Protection Act. So how do all these tie together? Thank you.
Good morning. I'm Faith Njoki Wakonyo, represented BMI and BMSG, Bunge Mashinani School of Governor. I'm here to learn more about SHIF and HIF. I want to know the difference between those two, and I'm happy to be here.
Hello everyone, I'm Melissa Patton with Umande Trust, and we focus on water and sanitation and the social and health well-being of people living in informal settlements.
Morning, my name is Daylin Murray. I work with Umande Trust. It's an NGO located in the informal settlements. We deal with water and sanitation, and we're here to learn how SHIF will help the people and their well-being in the informal settlements. Thank you.
Good morning, everyone. I'm Lewis Paul Washuri. I'm currently a freelance data analyst. I'm here to learn about the new SHIF, contrast and compare between NHIF and the new SHIF, and hear people's opinions on the new SHIF. Thank you.
I think we are good. We will save the last table, maybe after James, because I believe this is where we have representative from NHIF and the Ministry of Health. But we'll come to you later. But that said, allow me then to introduce Dr. Sierra, who is going to take us through the presentation, after which we can engage with the Ministry of Health and the NHIF representative and proceed. Thank you.
Thank you, Sarah, for that nice introduction, and welcome to today's launch. This some work we did some time earlier this year, and what we need to understand is to hear citizens' experience and opinion on health services and health insurance, because these are two things that you can't be able to separate. So, as we roll out to SHIF, there's need for us to understand what's happening, what has been there, the challenges that citizens have experienced, and even suggest on what need to be addressed and ways in which these issues should be addressed. We're also going to look at key issues that have led to the implementation of the current NHIF that we currently have, and get to hear what need to be done and citizens experiencing. Yeah, so we have a platform called Sauti za Wananchi, and this is where we collect information, or the tool that we use to collect information. So why Sauti za Wananchi? So it's a platform that helps to collect citizens' experience, perspective, attitude on issues that affect Wananchi. So basically what we do is to do surveys, online, phone surveys, and we're able to reach Wananchi across the country. And after identifying a topic, for instance, like the transition that we're going to have soon, we're able to package this information so it's timely, especially when we have something within a short time, we're able to put this information together. And besides that, we can be able to share that information, bring citizens, other stakeholders on board, including the government, and they can have a dialogue which will help be able to solve or improve service delivery. So the survey that we're talking about today was conducted between January and February. So the sample size was 3,603. So these are households spread across the country, starting from Mombasa to Turkana. There's a procedure. Allow me not to get into the details, the way the sampling was done to ensure that there is representation across different counties, different provinces and regions. So we had one or two challenges which we need to share here. That the survey included all those who are aged above 18. You know, when you have to interview those who are aged below 18, there are a few things that you have to do for you to collect information from them. The other shortcoming was that we have some pockets, although they are not many, where we don't have mobile coverage, but we did our best to ensure that we have good representation such that we're able to overcome this challenge. So this is a computer-assisted telephonic interviews. So we call people like for 20 minutes or 30 minutes because sometimes you don't extend the call. It creates fatigue and all that. So we're quite sensitive on that such that we can be able to collect quality information. About sampling error, we have plus or minus 2 with 95 confidence interval. Probably might want to share what sampling error is. For instance, we have an indicator like access to healthcare, if it's, let's say, 50%. So with a sampling error of plus or minus 2%, so the parameter is between 48 and 52. So basically, that's how we need to interpret the sampling error. And we are the ones who funded the poll. So in terms of experience, we are going to understand or to have, to get into details on 4 major issues. One is with the access to healthcare, which is quite important. We're also going to hear health insurance, as I mentioned before, issues to do with policy, programming and interventions. And as Melanie had mentioned, that you can't be able to separate devolution with health, given that it's a devolved function. We are going to get to hear probably health as a devolved function, probably it made citizens have or support devolution. In terms of access, there are a few things that we need to understand. Where is the decision made at household level? We understand, especially when it comes to care, it majorly lies with females, mothers and all that. When you get sick, mothers have that responsibility in African setting. But now, this is important issue when it comes to healthcare, of which we wanted to understand, even before we get into other details, to get to know if we have to target or we have to come up with a program or an intervention which requires addition to be made at the household level. Whom should we target? From the findings, we find that 40% of this decision, when it comes to healthcare, men are mostly involved, or they are the ones who have bigger say. Although we also find that 35% of these decisions are majorly made by ladies, but 40% is done by men. We also have some shared responsibility among the 25% of the household, but as you can see, in a way, it's a shared responsibility. So what does this tell us? Now with the 35% and 40%, and when you include the sampling error, you find men have a say when it comes to decision. And I believe mostly it's because there is some monetary implication, and basically that's why they have to say what has to be done when it comes to health-seeking behavior within the household. So when you look at the distribution, I also want to mention there are geographical regions that we have been able to identify, like Nairobi, where we have sufficient sample size such that you can just go to the database and then draw information or data from Nairobi. So we have Nairobi, other counties, and rural. And as you can see, there is no big difference. It keeps on going from 39 to 40, which is almost the same among male decision makers. We also tried to get to understand what's happening at the county. We have some counties of interest where we work, Elgeyo Marakwet, Vihiga, Laikipia. We divided Asa region into 2. We have Turkana, Mandera, and Turkana. Then we have Garissa, Wajir, and Mandera. Sorry, it's Tana River. The other one, okay, I'll get to that later. We also did and try to understand, in terms of education level, are there differences? As you can see, the higher you go, it's like inversely proportional, because we find in household where the man, or we have, the head of the household has high education, you find he or she has a say, especially among the men. We also looked at the source of income or source of, and found those who are formerly employed men have a larger share. Then the next thing was to understand when someone is in need of health care, where do they go? Because we have private and public. And from the results, we also wanted to understand, has this changed? Because we did a similar survey in 2017, and we found that 47% would prefer to seek these services from a government facility. Now, comparing to 2024, we found that there is an increase from 47 to 55. That's an 8% increase. In terms of private facilities, we found there is a decrease from 34 to 24%. We also understand that there are people who normally go to pharmacies. That has gone up from 12 to 21%. And we also have other places where people go to seek healthcare services. As you can see, some used medicine from the home or friend, went to church, health facility, went to herbalist, went to local groceries, or did not. The ones who go to local groceries, like going to a shop and then say, nataka panado and all that. So what we did also is to disaggregate the statistics, because we found, we also wanted to understand among those people who prefer to go to these facilities, get to understand, is the distribution the same based on the region and source of income? And we found that it's not all that, the difference is not all that big, because the average is 55. But we find in the rural area, it's slightly higher at 56 compared to urban regions like Nairobi at 52. But across the other counties like Elgeyo Marakwet, Vihiga, Laikipia, and Asa region, so it's something between 64 and 71%. And there's also not a big difference between among different sources of livelihood, because we found those people with high education, only 45 prefer to go to government facilities, of which on the other side, there's more preference among them to seek services from private facilities. Now, we also wanted to understand reason for not going to a health facility, because we have a small proportion of wananchi who think there's no need for me to go to a health facility, I need to self-medicate and such kind of thing. It's a perception issue, because from what we have here, some people think that it's not serious. Maybe the other reason, underlying reason why they think it's not serious, although sometimes it ends up being bad, but 64% say that the reason why they don't go to seek for these services because they think, based on their perception and understanding, that whatever they are suffering from is not serious. We also found that 3 out of 10 don't visit these facilities because of shortage of money. So it's issues to do with affordability. We have 10% who think that this facility don't have medication and there is no need for them to go to these facilities. And the other one could not get to health facilities. Probably it's located quite far and they make you wait for long. Probably it's one facility and we have so many people. So you end up spending the whole day for you to get the services that you need. And we have some people who prefer to self-treat themselves, and there are few health providers and all that. So everything revolves affordability and access, which are key issues that need to be addressed if you want to improve health services in Kenya. Citizens are more likely now to be satisfied with key aspects of their health facilities than 2017. So from what we have here, we did something similar to understand the satisfaction level and why they think what promotes the satisfaction based on their perception. And we made comparison between 2017 and 2024. So there's something which I commend the government for doing in terms of making, having more doctors and nurses in this facility, because you can see a sharp increase from 47 to 70%. The satisfaction is due to availability of nurses and doctors. We also found that time taken to reach the health facility of which we found, which I think in terms of building facilities is the work of the county government. We found there is a slight increase from 57 to 60, of which clearly indicates that we have more health facilities than before, though the gap is not all that big, or the change is not all that big. Time taken before being attended increased from 46 to 50%. So that's also another reason why they visit these services. And lastly, cost of healthcare in general, which it clearly indicates that there is a decline from 49 to 46. A clear indication that in terms of cost, affordability seems to be an issue that needs to be addressed urgently. Now, when it comes to finances, from what we have heard, that cost is a major issue that needs to be addressed. A few things that we need to understand: that citizens highlighted unavailability of medicine and the cost of healthcare as the biggest challenge currently being faced by the health sector. So from what we have here, we have results at national level. We also wanted to understand what's happening in Nairobi, where we believe or we think that we have better services compared to other regions, and the same thing with the rural area. So in terms of lack of medicine, which was at the top in terms of the challenges faced by the health sector, it was at 46. So on average, like half of the citizens think that we don't have medicine in these facilities, which Nairobi is at 38, which clearly indicates it's lower compared to other urban regions. The same thing with rural areas. The cost of healthcare was 23%, or almost a quarter, 1 out of 4. Think that the cost is a big challenge. So there's that need for the government to make healthcare more affordable. We have access to health facilities due to distance. That is access, something that need to be addressed. It's something that need to be addressed. Access to services due to lack of health workers. So we need more doctors, more nurses in these facilities. Issues to do with corruption, both at national and at the county level, were also identified as some of the key challenges faced by this sector. We also have that some of these facilities are unable to handle diverse diseases.
Is it for radio too?
Yes, we understand, like the current NHIF, we have those challenges in terms of the facilities where you can get these services, and even the number of problems that can be addressed there. So these are some of the challenges that we have highlighted, of which, as I've mentioned before, issues to do with the lack of medicine in terms of quality. The costs are the major issues facing the health sector. Half of the citizens have some form of health insurance. This is extremely important as we transit to SHIF. So we made some comparison, or we wanted to compare how things were in 2017 and 2024. 2017, 32%, or 3 out of 10 of the households have some form of medical insurance. It might be private, government provided, and some counties like Makueni, the county government have made possible for them to have a scheme. They given a card and they're able to access services at the county hospitals. So from what we have here, so we combine that. Never went into the details to get to know which medical insurance scheme they belong to, but generally there is an improvement from 32 to 53%. And when you compare men and women, you found that the difference is not all that big, from 51 and 54. The same thing with age. Unfortunately, those aged below 24 seems to lag behind when it comes to being enrolled to any medical scheme. And when you look at it regionally, you find Nairobi is leading with 71, that's 7 out of 10 of households. At least they have some form of medical, or enrolled to some form of medical insurance. Compared to other counties, things are not quite well compared to Nairobi. And when you go to Asa region, you find it's at 41 of. So this is something serious, of which we find are playing a big role in terms of them not being able to access health. When it comes to or in terms of health insurance, they enroll to medical insurance. The same thing with being in the formal employment. This is expected because whenever you get in one way or another, you have access to affordability. There are few things that they apply. So what we did is receive from NHS. When you say yes, we wanted to understand what particular aspect makes you happy with it. And 7 out of 10 of those people who are positive about NHS say members get quality, affordable health services. So that's something good to hear. We also have 3 out of 10 who say that it's much more affordable, probably compared to other things, that kind of thing. Now, the challenge here is for those people who don't like NHIF. One, they believe, of the population believe that not all ailments can be treated under NHIF, which I don't know at what level is going, something needs to happen. But from what we heard of the information that we collected, 190 believe that if you are sick, maybe suffering from a certain some kind of diseases not covered under NHIF, which I think SHIF should address this problem. You can only go to specific hospital. I think this is quite clear, especially when it comes to NHIF. You are restricted to go to a particular hospital. So I think the reason why they don't like NHIF because they are forced to go to a particular, as in when you fall sick in Mombasa and Nairobi, there is no way you can be able to use NHIF. You are not able to access services if treatment. This comes to compliance when you submit your dues. You find that sometimes you're told that your records are not updated, so you have to, you sometimes get denied the services. So the 3 main challenges the NHF system or those who are involved with NHF have mentioned that the reason why they don't like it, and they think these are major concerns that need to be addressed. Increase bill to get more money, so that's something that has happened before. And I think 10% of 190 expect that. Non-settlement of claims, so that's also something that was also mentioned, and expense premiums and all that. So we can be able to look at this in detail, so we can even conduct a qualitative survey to understand in depth of why citizens think that something needs to be done on this. And after asking the challenges, we also wanted to suggest such that as we switch to SHIF, the government can take into consideration all the agency concerned can be able to address their concern. We came up with proposals that for members to be able to be attended in any hospital. So if that provision can be in SHIF, I think half of the system, because from what we have is 49%, half would be, and probably we can be able to reduce the number of those who enroll to medical insurance from, we can increase it from what we had, it was 55 to something to closer to like 80%. Increase the funding to NHIF. Citizens think that NHIF or the current government scheme is not well funded. So they believe if the government increase funding that is channeled to NHIF or the current medical scheme that we have, 40% think that that's something can solve their problem. Include outpatient services. So this is something that was mentioned, of which I don't know it's because of awareness. I don't know whether NHIF have that services that they think that outpatient is one of the services that not provided under NHIF. That's something that need to be addressed. Improve the speed of the approval. Sometimes there is a delay. They think that it's important for when you go to a hospital, because the system, we have internet all over. When you launch a claim, immediately it is resolved and all that. Revise the bed charges, because majority of 190 think NHIF is for bed charges. So there's something need to happen, such that maybe it can be lowered for it to, if they have spent like 20 days, they can be able to, for NHIF to cover for all those days. So we have other reasons, although the percentages are small, but the major ones are revolves around access and affordability and the quality of the services they receive. Now, we're also going to hear some of the policies intervention that have been put in place, have been there before, of which citizens have an opinion on what need to be done. Now, what we did, we found that 1 out of 3 citizens know of an ambulance that can be called to their neighborhood. So what we wanted to understand is the understanding perception in terms of emergency services, of which we picked ambulance services, and we found that there is a decrease from 56%. In 2017, 56, almost 6 out of 10 of the household, they know, in case of emergency, I can be able to call this ambulance and get services. But now there is a significant decline to 35. I don't know why, but this is a major issue that needs to be done. In terms of emergency services, something needs to be done under the new scheme. And when you look at what the statistics across the country, comparing Nairobi to other counties, we have high access in Nairobi at 43% compared to other urbans at 39 and 31%. Now, a significant number of those entitled to free treatment do not receive this entitlement in practice. So what we did, the government provide free services to majorly 3, and I think there is the 4th one, children under 5, pregnant women, and those who are and the elderly, those above age of 60. Although this is something, a gap that we need to address, the people living with disability, that we need to have those statistics, although because of the sample size issues and all that, the numbers were extremely small, but it's a group that need to be considered when it comes to free services, of which we found in terms of access of these services, it's quite high among the 2 groups. That's children under 5, stands at 62. The same thing with pregnant women, of which we find that there is an increase from 68% to 79%. They have access to this, of which, given that these are free services, I think the statistics should be far much above what we have here, probably in the neighborhood of 90, but it seems that more need to happen for these groups to have access to these services. But the worst case here, we found those above 60 in terms of access to this. Only 30. The highest is 45. Almost half of wananchi, above almost 6 out of 10 of people over the age of 60 do not receive these health services. So more need to happen so that these people can receive whatever they're entitled for. Mostly the government has established community health workers. These people are quite key in terms of sharing information, even accessing some of the household where you have health challenges. And we found that when you ask that question to get to understand the awareness and if they have had interaction with this important group in the health sector, we found that almost 7 out of 10 have had some interaction or are aware of the existence within their communities. So, and then when we compare men and women, there's more awareness among men at 70 compared to 65, and it's not quite high in Nairobi at 66, although the difference is not all that big compared to other counties. So this is important because these are key people who can be able to, like when it comes to immunization and such other services, they are quite important in terms of helping wananchi get access to these services, and especially when there are new issues to do with health that the government want to communicate to the public, they are quite helpful in terms of making this information reach to wananchi. Now, the role of common health workers, because awareness seems to be high, almost 90%, but we also wanted to, they know the importance within the community. And we found that 55%, almost 6 out of 10, they believe or they think that they deliver health information and services, give first aid, vaccines, and all that to the local population. 38, almost 40% think that they make home visits to patients who are unable to visit health facilities. They are there to improve health-seeking behavior among citizens. Then 17% think that they facilitate in communication, connection, and care between patient and the existing health system. And 13% think that they help patients develop an understanding of what to navigate when it comes to health resources like clinic and insurances. They're also there to collect data from what we have here. Unfortunately, 22% don't know that what they are there. Yes, they know that they are there, but they don't know their role in the community. Now, I mentioned that devolution really helped to improve access to healthcare, and wanted to understand what's the connection between the two, because there's no way you can talk about devolution without mentioning health. It's a devolved function. And basically what we wanted to understand, and this is a survey that we had conducted before last year, between 19th and 27th of July, whereby we wanted to understand, do citizens support devolution? And if they support devolution, what are the reasons why they support devolution? And from what we found, almost 83% of who support devolution. Different demographic characteristic you find, in terms of support, it's quite high. So we had to interrogate to understand why do they support devolution. And it was quite interesting to understand that the main reason, which came number one, improve health services. So a clear indicator that if it can be scrapped, maybe for them to support devolution, health is one of the reasons, because they can be able to access. Although they have other reasons here, like improved road, bring government closer, but health was number one. And among those who do not support devolution, a small proportion or percentage, that 3%, say that the health services have worsened compared to how things were before. So this is a clear indicator that health contributes a lot in terms why citizens do support devolution, or the devolved function of the government. Now, there was something that we also wanted to understand. Yes, we found that we have this number, 43%, but we have another big proportion, that is around 57% who don't consider health as number one reason of why they support it. And wanted to understand why. It was quite interesting to find that they think it should be a shared responsibility from the statistics we have, because 30% or 3 out of 10 think that the county government is well suited to address their health issues. We also have 39% who think that the national government should be the one who should have a mandate to manage health. That should be a shared responsibility. That deeper in terms of understanding the 30% and all that, we found that in terms of access, putting up hospitals and all that, majority of wananchi think that the county government can be able to handle that well. But when it comes to quality, in terms of quality provision of medicine, distribution of doctors and all that, they believe if it's centralized, they can be able to get better services. So in summary, there are a few things that we have seen or heard as we transit to SHIF. One of the issues is there are challenges, and which we believe, as it will be discussed later, we found that there are still challenges with the current system which need to be addressed so that we can be able to have a universal coverage. And as we continue, find that most citizens are quite happy with the current system, and they believe that if some of the challenges that I've mentioned, I've shared before, if they're well addressed, can have more members be willing to enroll to the new scheme. And many citizens currently cite cost of healthcare as the biggest challenge that they're currently facing, and they may cite a lack of money as one of the reasons for not seeking treatment, when need or the main reason for not currently having a health insurance. We also found that access to insurance is currently strongly linked to location, education level, source of income, of all which are proxy indicator for wealth, and extending the reach to the insurance provision should be an effective way of spreading the cost over time, especially among poor households. So something needs to happen so that they can be able to access these services. Also, something to note is that NHIF members are currently most positive about it, about the scheme, but because of quality and affordability, but more need to be done to minimize corruption, to ensure that they get timely services, and if these are addressed, they would enroll more. The shift to SHIF is bound to be a challenge. The administration challenges of registering 50 million people, citizens, of testing, we understand and for you to be enrolled to the new scheme. We have comes to the other challenge that need to be addressed urgently for the rollout or for the transition to be smooth. That's all we have for today, and you can get this information, even the brief that you have, we have a soft copy from this. In case if you need data, you can write to us using the links there. For you, we can be able to interrogate the data further and even be able to get more information. Whatever I've shared is just a snapshot of what we have in the data. Thank you and have a good day.
Thank you so much, Dr. Harry. Shall we give him a round of applause, please? Thank you so much. Now, we have an opportunity to ask questions to Dr. Sierra. In case you have a question regarding the data methodology, the insights themselves, or anything, please do feel free to shoot those questions to Dr. Sierra, and I'm sure Melania can also come on board. But allow me to ask you one question, please. Having listened to the findings and having looked at that data presented on your tables in this, please tell me, what is the most interesting insight that you have observed? Or what is it that shocked you the most out of these insights? Anybody, please? What is that is most interesting? What is it that struck you the most? Or what shocked you the most? Kevin?
Thank you, Sarah. My name is Kevin Mabonga from Katiba Institute. So I'll not say that it shocked me, but it's something that I expected. The question about what 3 things would you like to be changed for NHIF to do better? And of course, I expected for members to be able to attend any hospital, and that has been a challenge in many ways. So it would be interesting, or I'll be keen to hear from the Ministry of Health how probably this can be addressed, if not any hospital, but increase the number of hospitals, because that now contributes to, when we talk of health as a right now, it moves closer to a reality. Thanks.
Thank you so much, Kevin. That's a question that we're going to preserve for our panelists. Betty, I'll pick 2 more questions and then we'll close that.
My interest is on page 5, figure 3, whereby women, there's a 5% difference on the percentage of personnel who have medical insurance. We can see that our women still have a difference with our men, and this is because of the unpaid care, domestic work, which women are having to contribute to do, but they don't have any income. Now, this one is challenging them because they do not have any resources to be able to participate and get medical insurance. And this one has now even been reflected in the Finance Bill 2024, when they say that they are going to impose a tax on and when we say we impose on diapers, means that our women will have to spend more time on domestic work, and will not be able to contribute they will not be able to engage in any economic activity. Thus, the gap will continue being huge.
That's a wonderful observation. Thank you so much, Betty. I'll pick 2 more from Mr. Suba and from Mr. Mugambi. Somebody, Josh, please, Gilbert. Please give it to Mr. Mugambi and then to Mr. Suba.
Thank you. I think mine is more of an observation in terms of the research methodology. I think when we are diving into trying to look at key factors that have been affecting the NHIF, the key players in NHIF, of course, there is the citizen who is accessing the service. But I think it could have enriched us more in terms of the policy and also what areas of that we need to capture when shifting. For example, there is a citizen who is accessing the service. But on the other hand, there is a service provider. Yesterday, I happened, from Laikipia County, for example, I happened to share with a private sector health provider. I think that was on, for example, on insurance. He was telling me yesterday that every month they have to go to the insurance provider to follow up the refunds, for example. What happens to the service provision? The facility will not give a quality service. It's the same, the other side. So I think maybe to this research, it's a wonderful one. It's citizen-led research. So to have a general aspect of now, so that we can be able to feed to the policy and the list, maybe as a consideration from Taweza. How is the feeling of just the health sector in terms of health insurance? And as they understand their role in SHIF, for example, what are the challenges have they been facing that has been compromising the service provision, which is, of course, referring to the citizen accessing the service. For example, you are taking to get the refund, some institutions, the services will be kind of compromised. I think we may think at how we bridge the two so that at the end of the day we can have a full picture of now what do we need to look into the SHIF now that has not been really considered at for example. Citizens complain, no medicine. Why? If there are resources, medicine will be there. But I don't know, there is no facility who don't provide actually major. Like if you treated, you are good chemist and buy the medication. Do you think the government or the county government hides the money? No, it's an issue of availability of resources or something. So we may need to get some bit of contributions from different stakeholders and see what is the gap in between, because so that now we can be able to make sure that the SHIF now addresses those gaps at both ends. Thank you.
Thank you very much. I'm Suba Churchill, and I wanted to, first of all, respond to the question that you raised. I find it curious that in response to the question as to who is the main decision maker in your household when making health decisions for your family, that it is the men that seem to have a higher percentage. Yet we know that health-seeking habits among men is the poorest. I find it strange. Is it because they are the heads of the family? Because men rarely go to hospital except when they are down completely. And that's why, mortality rates, the men tend to die ahead of the female counterpart in the family. So I find that very curious. Save for Vihiga, which is where the women seem to score higher. But again, for those of us who have done anthropology and understand our communities, we know that Vihiga predominantly a matriarchal society. And so I would understand why, in Vihiga men score higher, because we know the Maragoli, for example, are predominantly matriarchal. Women tend to be more authoritative in some of those communities, and the Maragoli are among those communities that are matriarchal. But having said that, allow me to use this opportunity to raise other questions that, so that I don't hog the space. When you say, first of all, the history. When some of us were involved in writing the Constitution at the Bomas Constitutional Conference in 2003, 2004, there was a push by stakeholders from the health sector to keep health entirely under the national government. And when we sought to find out exactly what was motivating them to say so, they felt that the terms of service would be better, that as workers, if they remain together at the national level, their voice will be more forceful in terms of agitating for benefit and so on. They find themselves splintered into counties, with each county having its own unions, And I have relatives who work in the health sector, and I ask them, why do you want this? They say, when it was under the national government, we used to be taken as far as Mombasa, Nyeri for workshops. Today, we are confined to local rank-shaft hotels as the executive gallivants all over the world, benchmarking and whatever. And so they don't feel motivated. So I would understand partly why. And then there was this push for a commission, a health commission that we never, appreciated. And I think they continue to agitate for it. But we never sufficiently got to appreciate the importance of a health commission because we did not understand why there should be a commission for a function involved. And that takes me to the last question. When the presenter repeatedly says it is a devolved function, what exactly do you mean? Because there is this notion that a devolved function is entirely in the hands of county governments. A devolved function is a shared function between national and county governments. Because you and I know that referral health, national referral, Mombasa should entice the to stop harmful use of mogoka and miraa, because the nicotine or content of mogoka is quite low compared to some of the stuff that we consume around. So I just wanted to emphasize the need to be clear when we say a devolved function and what it means, because it does not entirely mean that function is a preserve of county governments.
Thank you so much, Mr. Suba Churchill. I think we are well educated. I'll take one last question or comment, and then we will invite a Zoom comment too, and then we will shift into the next session.
Okay, one question for gender balance. I was surprised to hear that half of Kenyan citizens have some form of health insurance. I think the last demographic health survey found that 26% of Kenyans have health insurance, 1 in every 4 people. So it could just enlighten us how you found out that and if this is the case in the country. Thank you.
All right. Thank you so much. Allow me then to close because I cannot see any more hands, and then invite Jane Schuster. If you're online and you see a hand raised, let me know, and then we can allow them to speak. Jane, is there a hand online?
Not at the moment,
All
sir.
right. All right, thank you so much. So we are going to shift into the next conversation, which is basically us diving into whatever has been raised during this session, and also allowing James and Melania to respond to some of those things, as well as having our expert speakers speak onto the many questions that we have in the room. Right, but please remember that this conversation is happening online. It's happening using the hashtag @SautiZawananchi and also hashtag Afya Yetu, and please remember to tag Twaweza_KE. That said, there is tea being served. And it is being served outside exactly the same spot that we had our initial tea. So please feel free to walk outside slowly and then take a cup of tea and please come back because we will start the conversation right away. Now, we had mentioned in the morning that we have expert speakers from different organizations. We have a representative of the NHIF. We also have a representative from the Ministry of Health, and we've just been joined by Honorable Shakir Shabir. He has just joined, so we are ready to dig into the conversation. This time I also want to alert Dr. Sierra to first of all help us respond to some of the questions, as well as Melania as we pick on the panel. So Melania, allow me to welcome you to take on the next session, which is basically the panel. But as you do that, may I please invite you to stand and stretch? We've been seated for a very long time. Let's please all of us stand and stretch. It's very important. We need to remain healthy. We need to remain in good health. All right, please stretch. We used to ride coconut when I was younger. So I'm going to lead you on to ride the word coconut. It helps us to stretch and feel a bit relaxed as we get into a very serious conversation about what the difference is between SHIF and NHIF and all that kind of conversation. As we do this, you can step out, take a cup of tea, and then come back. All right? I don't know, but see, this is how we write. Bend, this is right. So let's all bend to the right, please. To the right. Up. And then C on this other side, left. And then O. And then N. And then T. Get that? So one more time. First C on the right, then O, then C on the other side, then O or not? All right, I see we're paying attention. Let's do that again. C on the right, O, then C, then O, then N, then T. All right, through that one more time. C, O, C, O. Karibu sana. And on stage, I think, if not online, we're also expecting Dr. Brian Lishenga.
Of element. So it's primarily a money game. And even the finding, even giving, put the various challenge which they are having. So we do take note of this. I think those are some of the few answers I wanted to give based on what this flow with us. Having said that, I'm not sure about our panel. I'm waiting for one beautiful lady, one Florence Ogola from the Ministry of Health. Florence. Thank you, my dear. And you're just looking at me and saying, oh yeah, oh yeah, oh yeah. Right. Right. But we will, yes, but we still want to have your feedback on, you can speak as Florence, not necessarily from the ministry. Well, let me share to the floor. So if those who didn't hear Florence, so Florence has said that for now they have no comment. Florence, if I'm have managed to convey what you are saying, that you have no comment for it. Right. Right. Okay, well, unfortunately, we don't have a lady with us. Do we have a lady online, Sarah? No, we don't have a lady online. So we have, so who do you have online as one of the panelists? Okay. So, since we still have people on the way. So Florence, is somebody from the, is the senior person coming, or they have sent their apologies? Oh, okay, great. Or they said no, they will let you know. Oh, okay. Great, great, great. We do hope they'll be here so that
the primary health care. That is many questions that you want to ask. So I want to Melania.
And then it's actually linked. There's a linkage between how much I pay and the service I get, or the premium. So probably if you could shed some light on that, vis-a-vis the service I get, million shilling. And then, do I get better, or how does that work? So that is one, I think, one of the audience mentioned. And then something else which I think, and we're not clear, maybe you call it, but of the informal, there is the mean aggregate of the income at household. So it's going to be calculated at the household in terms of, oh, these are my assets, and then the gain. So could you shed some light also how that will be done in terms of a fair, without any corruption element and harassment?
It's also 2.75. And what is also different from what was there in NHIF, previously it was voluntary. I hope we are aware, we know we are paying for our parents, or those who are contributing and are self-employed, we are paying 500, isn't it? We are aware of that, yeah? But what the challenge that we faced under that arrangement, where people were paying 500 and it was voluntary, we ended up with what we call adverse selection, where we had the majority of the people who are paying are those who know they are going to utilize. And you see now that affects the sustainability of the scheme. So to address that going forward, for the informal sector, it will be mandatory. The contributions also, there will be 2.75 of your income. There's a tool which has been developed, which we are calling the means testing tool, which will be able to assess your income. There are questions that you fill during registration when you are registering. Most of it will be digital. So during registration, there are questions that you'll answer. Once you answer those questions, there are algorithms behind those questions which will be able to generate for you the premium that you are supposed to pay, 2.75 of your income. Tuko pamoja? Ama tumepotea? Eh? Si mumesema you want to understand.
Very good.
Yeah, so sitaki kusema kutoka hapa mtu aseme tumechanganywa. Yeah. So the part of the questions is clear. So the questions will be touching on where you live, you know, the kind of facilities you have, if it's the toilet, the roofing, you know, those kind of questions. And that way it will be able to generate for you the premium that you are supposed to pay. Then the other question that was raised was on, in case of delayed premiums, the question is whether you'll be able to access services. The truth is we want this financing model to be sustainable. So to address that, what will happen is that we will have premium financing options. When you are registering, you'll be able to, you'll find an array of people who can, like the arrangement of ASLA Fund, Fuliza. So in case where you cannot afford, or rather, you are not able to raise your premium at that point, we will have premium financing options where you can click and whether it's a bank or whether it's the ASLA Fund, or whether it's Fuliza, you can Fuliza there, then the premium will be sent to SHA. Then now, as you continue generating your income, then you can repay the premium. That's an option. I'm not saying it will be mandatory, but we are saying, we all know the way life is. If you are not formally employed, there are times you have money, there are times you don't have money, isn't it? Or there is money you are waiting for. So naambianga mtu kuna kitu nangojea, kuna kadiri nangoja kaive. So as you wait, and probably you don't want to face challenges in accessing healthcare services, so unafuliza tu na bili ikiiva unarudisha. So you are sorted. Yeah, so that will be the arrangement. So chances are we'll minimize the default rate. So si hizo ziko sawa, kuna ingine?
I think watu wameshtuka bado. Even me hapa nimetetemeka sana. Nifulize tena kwa afya.
Si lazima kama uko na pesa si unalipa tu. But we are saying just in case you are facing financial challenges. Na unajua unangoja maembe yaive. Wale tumetoka Ukambani. Okay. So unajua nikiuza hiyo gunia, si ndio? Okay. So nitalipa hasla mimi niendelee ku access healthcare services.
Okay. Thank you so much, Mr. Bulingi. So I think
yes,
it seems like we have even more questions than answer, to be sincere. I don't know how the floor feel.
I want the questions so that we address specific questions.
Yeah, so what we'll do, we will allow you to kae watu wakiandika chini maswali, yes, ili to have Mheshimiwa and also Dr. Lushenge to have some few of, to share their thought. Lakini tutakaa hapa mpaka hii siku ishe, lazima tuelewane. So Mheshimiwa, please karibu. Mheshimiwa, for you, it's a very simple one. You are in the floor. The bill was brought. Well, I don't know if you are part of the people who are in the restroom when ilikoko inasainiwa, ama you are the people ambao mulikataa ama muli abstain. Sasa miyo sijui, utatuambia. But one of the things which we're just curious, and I think the floor had asked, is does this new fund address your constituency concern in terms of the challenges of healthcare that have been going through? Karibu.
Quick answer, no. I'm hoping that Churchill Suba is in the house, has not disappeared. Is he here? I'd like him to come in. Firstly, thank you very much. My name is Shakil. I was in the house. NHIF bill was brought through. Itapita bila kubadilisha full stop nini. People had no idea what they were doing. It was put through. No, I did not vote for it. Firstly, there is no short-term solution to any long-term problem. Isn't that the fact? And long-wise, no long-term solution to a short-term problem. NHIF, or what is it, has been with us for 57 years. Has it done what it was meant to do? No. It was there before. No. Who was there when independence? Maybe not you, you were not born. What was our independence call? Churchill might remember. Shelter, you can say it in Kiswahili as well. Employment, education, health. Health for all. Look at all countries worldwide. This is their clarion call, health. Now, my problem is this. I'm looking, when you're changing something, you change it for the good. You look at what we have, where the faults are, and then we come up with a system that can deal with those faults. And then, we have something in the model of change you call unfreeze, then freeze, and then implement. Yes? Firstly, we don't even know what NHIF does or used to do. National Health Insurance Fund. Do you remember? How many times have you heard that money has disappeared from NHIF? So we have no trust in NHIF. We start from a vacuum of trust. I have looked at this. How can you come up with a model? And I'm sorry, my brother. You cannot. And you have not addressed some of these issues. What is SHIF? It's just a different name for NHIF. People, these are intelligent people. They don't understand this Fulisa Nanini. What are we talking about? Less than 20% of Kenyans are NHIF. What is the problem with NHIF? They have listed it out. They're not covered, they're not this, they're not that. It's all here. It's all here. The major problems are here. And it says, members are unable to attend any hospital. There's so many issues, so many, that before you come up with a new system, Obamacare, Raila Care, Ruto Care, Shakil Care, in Kisumu with Marwa, we shouldn't send a check to SHIF. Do we send it to whom? Do you understand me? And he said, I don't know yet. Hold on to. I'll come back to you. He said, I said, I want this the following under writing. No, we're coming up with a Fulisa. We're coming up. Look, Fulisa in itself emphasizes having a problem. All these things, let's keep it simple. The situation, whether it's a new model or an old model or whatever, the question really is, does it provide the type of care that we want? I was in South Africa the other day, now 10 days ago. I was going around ID for Africa. This digitization. Guys, they came to me and said, listen, Mishima, we're looking to do something with NHIF. We have sent them our models. We have done it for India, we've done it for other places. So show me the one for India. Digital. You go anywhere in the country, it doesn't matter whether you are Uttar Pradesh or you are wherever. You go with your card. Digital. All information and everything that you have been treated, including that village doctor, is there. And then when you're being charged, you're told, you got a headache, go and get an MRI. What? This is what happens. I know it, people come to me. Malaria, enda chukua MRI. Because the hospital and the doctors are now kicked back with MRI. You understand me? What is an MRI? Many people don't understand. Why do you need an MRI for something that should not be done? So this has been misused. So we asked the NHIF, they say, oh, we don't cover MRI, we don't cover this. But this new digital system will be able to identify your particular sickness and your treatment plan, and the medicine you are allowed to purchase and what you're not allowed to purchase. And it will, you take your card and you give it there, and they will tell you, you're unclaimed, you got so much left, yeah? And so much you can claim. And then, if you reach the maximum, there's something called a pro bono, yeah, fund. You borrow from there. From people who have assigned their rights. Like me, I don't need an NHIF. I assign my right. So this is what the Indians do. This is what certain other countries do, Lithuania and other places. So my problem here, afraid, is the new model. And we've said this before, and I've been the chair of many hospitals. Aga Khan Hospital, 11 years. New Nyanza General Hospital, 12 years. I've been on the Kenyatta board. I've even worked on the health policy statements. I'm not a doctor. I am a citizen who understands what's happening. I want to talk to you, my friend Churchill. We were the CRC, Constitutional Review Committee. We talked about this. We made the biggest mistake. The idea was that primary health care remains with stays with the county and the first level hospital, if that. The rest must be moved across from national to what we might call parastatal or whatever. Now, when we talk about Kisumu, I was working in Kisumu. New Nyanza, I was the chair of the hospital at the worst of the times, but we never returned anybody for drugs. We never, even the mortuary bodies we dealt with. Do you understand me? So the system can be changed. System can be working. My problem, and I'm dealing with your executive, my brother. You can ask him. We are saying, my 3,000 people, 3,000. I'm not interested in anybody else because I'm a member of Parliament Kisumu East. My 3,000 people. Utapatia lini? Utapatia oneni? Where are they going to go? If they're in Nairobi, they arrived in an accident, can they go to Nairobi Hospital and be treated? Or they were told we're only doing rich people? No, we are going to this other one somewhere else near Bakati. What is the name? The Coptic Hospital. We only told civil servants. Hold on a second. No. There should be no problem. The issue is National Health Service. What can we do? Private hospitals, stay out of them. Then don't decide for us which hospitals. And then, don't you know that there was corruption there? Hospitals, you yourself, NHIF, have had problems. Can you acknowledge those problems? Put aside that. You are now trying to say that we are going to get compulsory funds to make up for the great hole that we have. Let's be blunt. You do not have the facility. You know, in your insurance fund, you have something set aside. It's your insurance, what do you call it? Yeah? There's a big hole there. So you're going to take compulsory, put it in there. And then you have to serve the people you have just taken the money from. It's going to be very difficult. The first thing you have done, you should have rescheduled your debts and find out, listen, hold on, NHIF is dead. NHIF is on this side, we owe so much money, we're doing this, we're going to sort it out. Go to the government, do whatever is necessary. SHIF is our new baby on the block. Please give me a bit more time. You're standing up, Melania, and I get worried. So give us time. And what we are suggesting is this. Give us time. You cannot put down the throats of wananchi a system we do not understand. Even us, we're having difficulty. What about those guys? What about my constituents? How would you? They don't know NHIF, they don't know SHIF, they don't know all these things, they don't know, as I said, universal health care. All they know, mtoto yangu ni mgonjwa, utafanyaje? Utafanyaje jamani? Then you are saying now, NHIF to SHIF. You yourself have not, I'm giving you my specific example, and please go and ask Elijah what he's done about it, because I've got a letter to that effect, and he's not answered yet. Beyond that, what is your rights as a citizen of Kenya? If you have not paid anything, what happens to you? You are like the Americans thrown out on the street. So we need to do this, and we need to know, those of us who are paying NHIF, what is it? What services are we being provided? Where and how? Keep it simple. Up to now, and I've been in the healthcare system for a long time, nobody knows. Nobody knows. It's politicized. This thing has been politicized. It should not have been politicized. It should just say simply, system, this is what we need to do. I would say, if you are not ready, please don't do anything. I want to say, Churchill Suba, when we were talking about devolution, remember we said, we will devolve. We're very happy about the devolution. I was the mayor of the city of Kisumu. The local authority systems were developed over 100+ years by the British, by the colonialists in their own country, brought it to us. When the governors came, they threw them out. Churchill, you were in the same committee as I was. We fought for transition committee. We didn't get it. Where is your transition, my friend? NHIF, WAPI. Who is it? Who is going to be that judge to say that you have transferred the following assets from here to here, the following services from here to here? Are you going to then, are we going to have a huge, huge problem with people's impression of what you're doing? And the wananchi have not recognized, nor do they own the problem. So finally, I would like to say, when you are doing a new system, whatever it is based on trust. Once you have done the system, put it back. Where were the faults? Where is the trust? The people, do you trust? You trust what the new system is? And can you then be able to, we start with the approach. Then we go to the change, yeah? We go to acceptance, trust, adoption, execution, experience, back to trust. Do you understand me? Are we trusting the system? Where are the fallouts? Who's going to fall out of the bucket? Who's going to fall out of the basket? How are we going to capture those guys? Yeah? Don't tell us either your insurance scheme or your national health scheme or whatever. Let's be clear on this issue. And if your insurance, let's say there's insurance, don't come to tell us about we are going to collect money. My brother, income tax is having a problem collecting money. Who is going to collect your money? Who is going to collect it? Nairobi City Council is having problems. You're going to collect it. I don't think we need to go all these systems. Keep it simple. Everybody knows they have to pay their 500 shillings a month. It's not much money. It's not much money. You make it 700, make it 700. Me, I pay, I think I saw my pay slip yesterday, 26,000. Tutalipa tu, sio mbaya. It doesn't matter. When I go to hospital, my insurance company pays, and you pay for me. And then when the bill comes, NHIF recovery, so much. 3,000, 5,000 a day or something. We don't need it. We don't need it. Why are you reducing, why do we want to go and cover, why do people like us not opt out of NHIF to be given the services? But we pay the premium. Those are the sort of things which we call pro bono. And I want to show you this card that I was given. Gives you everything. I have a card that was gave to me in South Africa. AI generated card. You take it, you give it treatment. And I think that's the way we should have gone. Where we are right now, I'm sorry, we are heading to a, nobody knows where we are going. And every time we're coming up with a new system, it's the first time I've heard about this police system. And you see the sarcasm. Do you understand me? It's not going to work. So let's come up with something simple. Let it be 700 shillings a month, 800 shillings a month, 1,000 bob a month. Let's understand it, yeah? And then let our private, and let our hospitals also understand it. And also realize and accept certain hospitals have been doing surgeries which were then, they don't even have an operation theater and your people are sitting there and deciding that so-and-so can do a surgery. I've called you guys. So-and-so is doing this. You're sitting there, you're not even an accountant, and you're approving surgeries. So I think those are the things that we need to sort out at your level. Thank you very much.
Thank you so much, Mheshimiwa Shakil, for that heartfelt message and your appeal. And I think when you are talking, I could see many people resonating with your message. And to me, what was going in my head was if Mheshimiwa, who the bill passed and it was signed with other Waheshimiwa in the floor, can't even understand it, then what happened to my mother or me? Okay, so what happened? They are crying, saying, tusaidieni. Sasa mimi mtu huko wa mlala hoi, yani mwenye shida kama mimi, inakuwaje? So I felt so sad for myself. But I think we are very glad for those thoughts. And I'm sure the floor have quite a lot which they'll throw back. I will welcome Dr. Lishenga. Dr. Lishenga is the chair of Rural and Urban Private Hospital Association of Kenya. And then after that, after he shared his thought, and then I'll open discussion to the floor to share or raise a number of questions to the three speakers so that they can even have more in-depth knowledge of this particular fund, because we're really concerned. I mean, it seemed to be very personal. So, Daktari, being a chairman of RUFA, if you look at the media, you look at public discussion, the things that have been coming out is the issue of non-settlement. Mtu anaenda hospitali, anafika huko, mara anaambiwa, fine, first and foremost, your NHF money has not even been updated. The hospital tells them, the hospital tells them, oh, we don't even take this card anymore. They haven't paid, the money which you have, you've been contributing. And when you look at all, probably your pay slip or all the receipts, I have even people these days who are going to the hospital with files. When you are sick, you are working with files in your, not even your health, your NHIF card, file of receipts to go and show that, or when you go to the hospital that you'll not be nice service because of those non-settlement. Dr. Lishenga, being that the new fund is supposed to commence in July, how confident do you feel that the issue of non-settlement won't arise with this new fund. That's one. Second, what opportunity and or challenges do you foresee in these new funds? Please, Karibu.
Okay, thank you, Melania. Let me check. What time is this? It's still morning. Okay, fellow citizens, good morning. My name is, as you have heard, my name is Dr. Brian Lishenga. Just a brief introduction of who I am, besides what Melania said. I'm a medical doctor for the last 17 years. I know I don't look, but yes. Actually, it should be 18 years, but I was very much involved in student politics when I was at the university, so I got suspended for a while at University of Nairobi. So I have been practicing medicine for 17 years. I currently chair the Rural and Urban Private Hospital Association of Kenya. My background is family medicine. I am a family physician, so my focus is primary health care. I have also been teaching at Egerton University School of Medicine for the last 14 years and chaired this association for the last 5 years. So just like Mheshimiwa, I think we share a lot of experience with the health sector. I have been listening to Daniel and Mheshimiwa Shakiri speak, and I was just wondering which path do I take? Do I lean towards Mheshimiwa, who is so much on the left, or do I lean towards defending NHIF? As a provider, this is usually a very difficult task. I'm just wondering where to be. So if you allow me, if you forgive me, and I will answer your questions, Melanie, as well. If you allow me to walk sort of like a middle path a little bit and try and be the pragmatist in this discussion. Because of my experience as a provider and also as an advocate for better healthcare. So number one, I usually answer questions around this transition by reminiscing a very old movie that's called The Good, the Bad, and the Ugly. So this is how I usually start this. So is there any good that is coming out of this transition? And I think as a citizen and a professional, I have a duty to tell my fellow citizens whether there is any good, so that we don't throw out the baby with the bathwater, as they say. So what is good? I will tell you what we think as professionals is good. One, there is a good intention to raise more money for healthcare. There is a good intention to raise more money for healthcare. We do not have enough money within the healthcare ecosystem to take care of all our medical needs. All of us here will need a doctor one day, one time, if we have not needed a doctor already. And when you go to hospital, the most dignifying thing you expect is to receive the care where you need it, when you need it, at a cost that you can afford. Now, I looked at our health accounts for right now for this year, for the year 2023. The national health accounts is the total expenditure we spend on health. Whether you are paying out of pocket or using insurance or your relatives are doing mchanga, whatever it is, as long as that money ends up in the healthcare system. And as at 2023, it was 550 billion Kenya shillings. So, back to the same year, 2023, how much money did NHIF collect? NHIF collected 82 billion. So just to put you in perspective, we spend 550 billion, NHIF maximum collected 82 billion. So healthcare is grossly underfunded. Where does the rest of the money come from? The rest of the money comes from you guys. From your, you sell a property, you sell livestock, your relatives hold a fundraiser, that's where the rest of the money is coming from. And even if you combine what people who have private insurance are paying, private insurance is about 40 billion a year. So in combination, we're talking about 120 billion private insurance and NHIF. So you still have a shortfall of something like 400 billion shillings. This money we don't have. It's not available in our health system. And that is why you constantly hear something called catastrophic healthcare expenditure. That is, most of us are one serious disease away from poverty. You understand that? Eh? So there is a fantastic intention to raise money. The second good thing with this fund is the issue of the chronic diseases fund, the emergency, critical, and chronic diseases. The second good thing about the change. Why is this so critical for us is because, and you know, I see a lot of our advocacy friends in the room. The Constitution of Kenya, I think Article 43 guarantees us, you know, the highest attainable standard of health, and I think there is now a constitutional protection for persons to be given emergency care. In other words, if you are knocked out by a car crossing Wayaki Way here, the nearest hospital here should be able to render you care whether you have money or not, at least to stabilize you before, you know, we figure out what now, who are you, where do we take you. So no hospital is supposed to turn you away. However, this hasn't exactly worked out that way. Why is this the case? Because if you have ever been in this situation and you ended up at any of the hospitals here in Nairobi, ultimately, they will ask you to pay money. Isn't it? Ultimately, they will ask you to pay money. And the reason has been that there is no definition of what is the period for emergency care. Is it 1 hour, 2 hours, 24 hours? What is that period? And who is responsible for the costs accrued? Remember, these hospitals will accrue costs to take care for you in that period. Whether it is the nursing staff, the drugs, stabilizing you, CPR, all this stuff, who pays for that? So there has been, that question remained unanswered. Now, there is an attempt to answer that question with the new laws, which is provide a fund that can pay for any Kenyan, as long as there are caveats, of course, as long as you are a paid up member of the fund, which now is mandatory, right? You understand? So I have looked at the money that has been set aside for emergency treatment, and I can tell you the good news is that that money is significant. Significant enough for a hospital to provide you care without you having to go back into your pocket. So if things pan out the way they are planned for the emergency, chronic, and critical illness fund, it will be possible for any Kenyan to actually be taken to Aga Khan Hospital, which would be probably very expensive, and for the first 24 hours, Aga Khan Hospital is guaranteed that it will be reimbursed for the cost of care. So that is a good thing. Now, let me see if I still have one more good thing. I told you my approach is the good, the bad, and the ugly. So let me exhaust the good stuff, because because by the time I get to ugly, you might have forgotten all the good I have said. Just give me a second. I have my notes here. All right. So primary healthcare is the other good thing they have attempted to do. So what these bills attempt to do is to create a referral system to decongest our larger hospitals, our level 5 and level 6 hospitals. So to explain to you this, today if you go to Kenyatta National Hospital, outpatient, Kenyatta National Hospital outpatient is more packed than Mbagathi level 4, which is across the street. Do you understand what I'm saying? So Mbagathi is across the street, is level 4, but the outpatient at Kenyatta National Hospital is much more packed. And because this is where I trained, the vast majority of people in that outpatient have common ailments. So they have a skin rash, they have a sore throat, they have a flu, they have a pneumonia, etc. If you ask anyone who knows about healthcare systems, this is not an efficient use of our level 6 hospital, which is supposed to be the point of last referral if things really have gone out of the way, because the people you have at Kenyatta are supposed to be focusing on the really difficult problems. That is the ideal situation. But the situation we have in Kenya today is you get sick, you go to the hospital which has the best name. And the hospital which has the best name, which does the best procedures, if it's public, you'll say, either I'm going to KUTTRH on Thika Road, or I'm going to Kenyatta National Hospital, and you just have a sore throat, for God's sake. But you know, at that time, that sore throat, you are thinking, this is a heart problem, I am dying. you know. So there is an attempt to legislate around that so that we efficiently use the highest level of resources. But also, this approach has had a very negative effect on our level 4, level 3, level 2 hospitals, because the fact that there is no footfall there means that those hospitals don't generate revenue, and therefore those hospitals keep remaining backward. But if we were using those hospitals would generate revenue and they would be able to invest in better care. So there's an attempt here to create a referral system for primary health care that now is going to mandate Kenyans to go to a level 2 or 3 facility first before you can end up in a level 4, 5, or 6 facility. That is now what is in the law. So once this kicks in, you will not be able to walk to a level 4 facility and say, here is my SHA card, Social Health Authority card, I want treatment. No. What will happen is that they will tell you at your level 4, 5, or 6 to pay cash. If you don't have cash, they will send you back to your level 2 or 3. It is the level 2 or 3 facility that will decide whether your condition requires a referral to a level 4, 5, or 6. I think that is important information for you to know. So I know that is like a mixed bag. It sounds bad, good, ugly, you know, but for a healthcare professional, I think it is probably a good thing. Now, what is the bad? I hope you will remember that good thing, the bad. So the first bad thing is that there is a requirement to register all Kenyans as members of SHA within a very short time. Now, this country has 55 million people. Even IEBC has never pulled off that kind of registration. We don't have the infrastructure that is required to register all Kenyans in less than 6 months as members of SHA. And remember, if you are not a registered member of SHA, you do not have access to health care. So what does that tell me? It tells me that the whole process is extremely rushed. It is extremely rushed and extremely ambitious, because how are we going to get 55 million Kenyans registered within 6 months? I don't know even if we can do it within 1 year. So that's a bad thing. The next bad thing is this issue of premium financing. Mheshimiwa, you were talking about. The issue of premium financing, Hustler Fund, Fuliza, etc. Let me just explain from our perspective as an association of providers why it is bad. It is bad this way, that imagine you are Fuliza to pay for SHA, and then you can't pay. You can't pay your Fuliza, isn't it? You can't pay your Fuliza. So now, even before we talk about the company that gave you Fuliza closing down, you yourself, for the next year, you have 2 problems. One, you need to pay the premium for the next year, and you need to pay the debt for last year. Now, if you look at the regulation, it says that you must pay the premium for the next year 2 weeks before the next year starts. So essentially, what will happen to you is that last 2 weeks, if you don't have the Hustler Fund premium and you don't have the premium for the new financial year, you will be struck off the register. So this is a bad thing. So in essence, we are exposing Kenyans to what I call a double whammy. In other words, you have a debt. Yeah? Yes, it's reckless. You have a debt with the Fuliza Fund that you are unable to service. Remember, you got into the debt first because you have financial problems. It's not because you are well off. Now, you are unable to service that debt, and the law keeps on saying the cabinet secretary, the cabinet secretary, the cabinet. So we do have in place a puppet board, if you ask me. A board which has no power to actually make decisions. And I usually feel for providers, because providers take their petitions to the board, but the board indeed is powerless to assist them, because the only person with real power is the cabinet secretary. That centralization of power is dangerous. Now, why is it dangerous? It's dangerous because the cabinet secretary is a political appointee. So instead of us professionalizing SHA, we have turned the SHA board into an apolitical appendage, which is very dangerous. Now, let's talk about the fourth ugly thing is privatization of claims management. Claims management under the new laws has been privatized. So before, and you know, those of us who are in the know think that this is one of the reasons why these laws were brought. Because as an association, our feeling was, why do you need to do all this? Just, you know, reform NHIF and we are good. I mean, what's all this? But we think that there was a financial incentive as well, because the claims management of this new expanded behemoth is now going to be privatized, and it will be put in the hands of private companies. And the country now has been zoned. Initially there were 8 zones. I think now there are 11. I've not looked at the real numbers. There are probably 11 now. So the country has been zoned, and private companies will be given zones in Kenya to manage claims from those zones. Now, for me, why that is dangerous is that the real danger is now you have created a new private bureaucracy instead of the singular bureaucracy that we were dealing with. And then, in addition, the number of private sector claims agents that are rogue in this country is too many. You know, in other words, if you people are familiar with what is going on with the teacher scheme and the police scheme, which were moved from NHIF to private hands, nothing improved. That is what I'm saying. So, in other words, it is not an improvement to move claims management from NHIF to private hands, because we have current living experience that it does not improve things. Instead, what happens is that private companies are motivated by profit. And since they are motivated by profit, they tend to cut more corners. Our fears is that Kenyans are going to be denied benefits so that these private claims management companies can make much more money. So that is one of the really bad things about these bills. Now, let me just go to the outright ugly. So, this is now where I think the ones I'm about to say, these ones should just be thrown out like tomorrow. So this whole thing of means testing, Mr. Mulinge, this whole thing of means testing is ugly, because we are in a country where about 60% of the population is unemployed. People don't have jobs. Our unemployment levels are very, very high. Now, for simplicity, let me explain what means testing is. So means testing, I think Mheshimiwa, I think you tried to explain, but I put it more graphically. Somebody coming to your house and asking you how much do you spend on sugar per month, how much do you spend on soap per month, how much do you spend on majani chai, okay, what is your rent, right, how much do you spend on boda boda, and they calculate, because remember it's called means proxy testing. The key word there is proxy. In other words, we don't know your income, but we are going to use your expenditure to approximate your income. You understand what I'm saying? In other words, the argument is that you cannot spend what you do not earn. So, but which is false, because we have, especially our elderly population, our senior citizens, most of them spend what they do not earn because they are supported by their kids. You understand what I'm saying? So if you went to an elderly house and you did proxy means testing, you will burden that household because their expenditure is disproportionate to their income. Now, let's keep going on that. So this proxy means testing is targeted at the informal sector. So the argument is that there are so many Kenyans who are not on salary who make a lot more money than people who are on salary. So we need to target those guys because they have not been carrying their weight. They have been paying 500 bob when they could afford to pay 2,750 or 10K. So we are targeting those guys. My fear is, and this is going to happen, and you can treat me as a prophet on this one, it's definitely going to happen. Everybody is going to understate their expenditure. Literally, like this is a bad idea. Even people who have any side hustles, they will completely hide those things. They will not reveal. I mean, if you know that you are going to be charged 2.75% of what you declare, you will declare less or more. You're going to declare less, isn't it? So there's no way I'm going to declare that I make $1 million from my side hustle so that you can tell me, aha, you should pay 27,000. So what is going to happen with proxy means testing is that those who earn much more are going to be incentivized to lie about what they earn. Number one. Two, there is also an incentive for the very poor to also inflate what they earn because of stigma. You understand what I'm saying? Because of the attached stigma to it. Because remember, once you declare that you don't earn money, you are going to be classified as an indigent. Now, once you are classified as an indigent, that itself is a stigmatizing term. And you now end up in what we call the indigent pool, where now we will be using appropriations from Parliament to pay for you. Now, there are people who are going to say, Mimi, I don't want to do that. So even though they are actually struggling, they will not say that I am struggling. Now, a third problem with means testing is that it defines a household not the way you think a household is defined as people, a community of people who live together. A household is defined those two ways, people living together, sharing an abode, but every Kenyan above the age of 25 is a household on their own. Now, you guys don't know this, but this is the reality. So if you are above 25 and you are living with your parents, you are a household in that household. Okay? So, the definition of a household is twofold. People living together, sharing an abode, isn't it? But it is also any person above the age of 25. No, that is also in the law. So unless you can prove that you are in school being paid for by your parents. But they did the mathematics very, very cleverly, because even for the longest courses, like now medicine, where we take 7 years, most of us are out of there by 24, 25. So truly, if you are above 25, you are not in school. But you could be unemployed. You have nowhere to go. You are now defined as a household within a household. So you must make your contribution independent of that household's contribution. Please know that. So as your parents pay, you also pay. Now, whether you have a job or not, doesn't matter. Now, that also means for couples, the extra person pays, so husband and wife, right? So one of you is paying on behalf of the household. But assuming that the other party is over 25, that other party also pays. Yeah. So let me just speak to the facts. Now, I know what Daniel will say. We have this back and forth with our friends from NHIF all the time. But what I am telling you is the fact. The fact is that if you are over 25, you are a contributor independently. That is the fact of the law. So, and that is classified under my list of ugly. Now, still on means proxy testing. The law has fixed the administrative expenditures of SHA at 5% of whatever they will raise. So the administrative expenditure is fixed at 5%, which is on paper a magnificent thing, because right now NHIF is spending 11% of its collections on administration. So which is not in line with global standards. Global standards are somewhere between 2 to 5%. So NHIF is spending so much more of the money you and I give it to pay salaries, fuel, cars, put billboards, posters, things, administration. So now they have been capped by law to keep that expenditure at 5%. Why am I connecting this point to means testing? I want to submit to you guys that the only agency in this country with the capability of doing something close to means testing is IEBC. The only one which has something close to that infrastructure. And now you realize how much money IEBC requires to do a single round of voter registration. It is in the billions of shillings. Now imagine NHIF is telling itself, or SHA is telling itself, that it is going to do means testing for, wait a minute, for 13 million households. 13 million households. That's the number of households in Kenya. This is an impossible task. Even if you wish, if you jump, come up, go down, you can't do it. It is not possible. So they are not going to do means testing for 13.6 million households, not possible. So what are they going to do instead? They are going to do sampling through the Kenya National Bureau of Statistics. The danger with that is that you will be assigned an income that is not yours just because you are in the wrong geography. You understand? So you just happen to be living in an area somehow classified as high income. There you are. You are paying like everyone else. So I'm not just going to say this and say there are no solutions. We were against means proxy testing because it doesn't work. Means proxy testing is a tool for rich nations, not for poor nations. We are a poor country still. What we should have done is been bold enough because we wanted more money, and this has been the position of the Kenya Medical Association, the position of the Rural and Urban Private Hospital. Everyone in the health sector, we have told government that if you want to fund healthcare, find a way to do it through general taxation instead of doing it through people's income. We are a country where the number of people who are employed are too few. Therefore, we have too little incomes for you to tax. So what is going to happen is you will burden the few, and then you are trying to catch the others by using a tool that is defective. So this is very bad. Now let me move to the next ugly one. But that's the main ugly one, so I'm about to finish. So job loss. Let me talk about losing a job. In this new regime, if you lose a job, it could be one of the worst things to happen to you. Why? Because that is a difficult period, because there will be the SHA will have your data, your proxy data, based on your last job. You understand? I just want you to follow me. They will have your proxy data based on your last job. So if in your last job you are earning, say, 100,000, your payment is 2,750 per month, you are now unemployed. Isn't it? Now you are surviving on your side hustle. Now, for them to calculate for you your new payment level, they must do proxy means testing for you. Now, SHA is not able to do proxy means testing for everybody who becomes unemployed because they don't have the capability. So what will they do? They will continue to insist that you pay at the level that you are paying when you are employed until the time when they will do the next proxy means test and find out that, oh, kumbe, you don't have a job. So for me, this is a problem, and that's why so job loss, for me, job loss is going to be a serious issue. That transition between jobs, or if you lose a job, the time they reclassify you will be a time where you will be struggling. You are jobless, you are still paying at the rate of which you are paying when you are in job. If you stop paying, you are out of the scheme. Okay. Now, there's this thing called the Central Digital Platform, which my friend Mulinge was talking about. Now, I don't know why government wants to do this. I mean, on one hand, you say you don't have money, and then on the other hand, you say you want to spend 5 billion on a new centralized digital platform. What for? What is wrong with the platform that NHS? And this is why it is so amazing to me, because they actually put that in the law. I mean, how do you put that in the law? Like, I'm going to spend money on an expenditure line. It doesn't make sense. That is something you do in your budget. You don't do in the law. The way they put it in the law is so that to make sure that it must happen. You know, like, we have to do this one. So they put the centralized digital platform there, and they have a budget for 5 billion on that. We as healthcare providers are not happy with that. Because over the last 4 years actually, NHIF has spent already 4 billion shillings changing platforms. Even the one they have now is about a year old. Before that, they changed. So it is, and whose money are they using? They are using contributors' money. So we found this to be very imprudent. But my contention is not just the money they are using. Why are we spending on that platform, and yet, it's a claims platform, and yet we have decentralized claim management to private companies which already have platforms? Make any sense? So Jubilee, let's say, if it's an example, if Jubilee is given the work to manage claims from Nairobi region, Jubilee itself already has a claims management platform. So why would we have a budget also in SHA to do the work that we have given Jubilee to do, and we put that in the law? Doesn't make sense. We ask them a simple question. These 5 billion shillings we want to spend on a platform, how many Kenyans would it be able to insure per year? That is the cost-benefit analysis. Because if you ask me, 5 billion covers a whole lot of Kenyans. So, now to your question, Melania. To your questions, Melania. So as at today, NHIF owes providers about 22 billion. Okay? No, I'm right, NHIF. But the transitional clauses in the law said that those liabilities now belong to the Social Health Authority. However, today, the Social Health Authority doesn't actually exist as a financial entity. So the persons who are still paying is a defunct entity known as NHIF, which doesn't exist. Our concern was this, all these claims which are historical, when we ask them when will you pay them, they moved the claims to the Pending Bills Committee. I think you guys know the Pending Bills Committee, isn't it? They moved the claims to the Pending Bills Committee, about 20-something billion, 22 billion, which is money that has accrued since 2005. We have hospitals that still claim money that far back. Now, that money is in the Pending Bills Committee, and eventually, we are told the money will be paid after it has been verified. The question is, to whom will it be paid? So, the idea that we are concerned about is because we have a contract as providers with SHA, or rather NHIF, that says claims must be paid within 90 days. The SHA will keep paying us. Do you understand? SHA will keep paying us as providers, and yet there is a pending bill of 29 billion somewhere in Pending Bills Committee. But where is SHA getting the money to pay me? It is getting the money to pay me from your current contributions. Not from the previous contributions you already made, from your current contributions. So eventually what's going to happen is that 29 billion, 22 billion that is at Pending Bills Committee, once it is approved, it will end up in hands that we don't know. Because the providers were already paid on your new contributions. When you skill. So finally, I'm going to say something about financing of the 3 funds that I find extremely problematic. When we looked at the budget policy statement for 2024, so I started by telling you the national health expenditure is something like 550 billion. When we sat down in meetings to calculate how much money or how many tariffs, because they invite us as stakeholders to give our opinion, it turned out that to finance healthcare for all Kenyans and pay for everyone, everything 100% on face value requires 700 billion. Not even 550. So that if you wanted a country tomorrow where you can just walk in, walk out, nobody asks you any questions, we need about 700 billion. But then an instruction was issued from above that number must come down to 250 billion somehow. Yani you say, mimi nataka kuspend so 7, unaambiwa tafuta njia ya kufit kwa so mbili. That was the instruction. So it was 250 billion, but what does 250 billion mean from 700 billion? It means you who is seated there expect that your life is going to improve in healthcare dramatically because that is what you have been promised. But the reality is that the benefits that you are going to get under SHA will be no better than the ones you have been getting under NHIF. You understand what I'm saying? The benefits will be no better. Now, we asked them, this 2.75%, how much do you think, what is the yield? What is going to come out of it? The best mathematics that the architects could come up with is we are going to raise about 140 billion from taxing Kenyans. Now, that leaves us with a shortfall of 110 billion. based on their budget, which is already scaled down. So it means, let me just bring the point home, it means that Parliament has to appropriate 110 to 120 billion in the first 2 years to fund healthcare. This has never happened in the history of this country. You know, Parliament operates on something called budget neutral something. So they will not touch it. So they must increase healthcare funding by 110 to 120 billion. Now, when you look at the budget policy statement that came out the other day, money to the Ministry of Healthcare was actually slashed. You understand what I'm saying? Not increased, actually slashed. Now, what does that tell you? It tells you that whoever is pushing this agenda is not putting their money where their mouth is. It is totally not serious. Because healthcare is being given something like 160 billion this financial year, which is a reduction. Yet they asked for double that, 328 billion. The money which has been slashed was supposed to go to 2 funds. The first fund is the emergency and chronic illnesses disease, which in our estimates, at the very minimum, hata kama tunachuja aje, was supposed. Do you understand? Number 2, primary healthcare in our best mathematics was supposed to get at least 50 billion. What has been allocated to it in that budget policy statement is 4 point, actually, I know it's 12, but I saw 4 point something billion. In other words, you and I will faithfully pay our 2.75% into the SHIF fund, which is only operational at level 4, 5, and 6 hospitals. But government, which is supposed to fund PHC and supposed to fund chronic illnesses, is actually cutting down its allocation to those funds. So in other words, I don't know where money for primary health care will come. And remember, the same law has demanded that you cannot go to level 4, 5, and 6 before you go to level 2 and 3, which don't have money. I hope you have understood me. Asanteni sana.
Yeah, I'm actually feel dizzy. No, I had to, my blood sugar imeshuka sana. Kwa kweli, no, sidanganyi. Imebidi ninywe nile pipi, So mbona Sara, kama nimebadilika kidogo. Truly, thank you. Daktari, thank you so much. That was so detailed. I think many of us are still processing that information, to be sincere. But we thank you. We thank you. That is very, very detailed. So, Juma, coffee for Daktari, please. I think that was detailed. Having said that, first I want to thank kumshukuru Mr. Mulingi kwa kuja. Though moto imerushwa kwake, he's still holding firm. He's still smiling there. Anasema hakuna kitu hapo, mimi nakuja narudisha. So of course he has a right. He has a right to rebut some of things which the two speakers said. And then why I'm thinking him is he has another meeting which he has to attend. So he has a right to rebut and to just make any addition. If there's some things which were probably misrepresented or he feels that they need to be corrected. And then I'll open at least some 3 to 4 questions to the floor related to Mr. Mulingi. So kama kuna ninio Filba, Sara mtachukua some 3-5 questions ili at least Daniel aweze kujibu, watu wasione kwamba ameenda bila kutujibu, and I know he's very anxious. He really wants to answer this. He's very passionate. Ameambia Melanie, I will not leave here until I address some of the issue. So Daniel, please karibu. You have the right of rebut and also address some of the questions from the floor. So let's pick question. Daniel andike from the floor ili wakati anajibu hiyo maneno zingine zilisemwa na pia hizo zenyu pia ajibu. They could be answered in those questions. Si ndio? Wacha waulize alafu wewe wakati una That is why I'm saying waulize and then inaweza kuwa jibu iko hapa. Ama wewe unaonaje? That is what we wanted. Please make the question short. Kama tayari zilishasemwa na the two speaker, please usiulize. Okay. Yeah. Okay, sawa, sawa. So Daniel amesema msubiri, just hold your horse. So he wants to react first. He'll say ni kitu ndogo sana, hizi msumbua, and then he will open some questions.
Yes, thank you. First, I think you didn't clap enough for Lishenga because I think what he has given you is an eye-opener of the issues that you need to look out for. I'm happy he has looked into the documents properly. So unless you go through them, you're not able to pick some of those things. But what I would say, any change of policy, there are always teething problems in terms of implementation. So overall, what you said and what Mheshimiwa said, most of them are legislative issues. So for me, all of us, a person we should be asking questions now is Mheshimiwa. Because those issues were dealt with at the parliament. For us, we have been thrown to implement, isn't it? So Mheshimiwa, you make sure that he answers all those issues that you are raising. You saw them in parliament, isn't it? So you need to go back and, isn't it? Yes, so Lishenga, I think I will only pick just a few operations issues, maybe I need to clarify. For the means testing, I think you've done a very good job, but it's the only issue that there are no plans to use Kenya Bureau of Standards. I think what is likely to happen is that most of it, at the first stages, will be self-reporting in terms of answering those questions. Then gradually, I think the means testing, we are hoping with time it will be perfected. The other issue was how to go about registration. Yeah, registration, he said it's likely to be a challenge. It's a yes and no question because there are very many ways of doing a registration within a short period of time. And this mostly when you look at partnering with other institutions, and the process will also be digital. So registration might not be so much of a challenge. But I agree with him, it's something that is on the table being discussed. But there will be solutions for that. Then the other one is the issue of system change at NHIF. Just Lishenga, we have not changed our ERP for the last 20 years. We still have a legacy system. But plans were there to upgrade the ERP. That was not done. So I just wanted to clarify that. We have not been changing our system every year, but we wanted to change, but we didn't do that. We still have a system which has served us for the last almost 20 years. All right, so that's why there's a need to have a new system. So with that, I think I'll pick specific questions. Yeah.
So let's pick questions, not just for Daniel, now also to Mheshimiwa and Daktari. All right? Hands up, please. We have more microphones, so we'll keep. Okay, 5 questions first, and then we'll do another round. Please help us to check if there are more questions online. We've left out that audience. So we'll start with this gentleman here, number 1. And then Mr. Suba, number 2. All right. And then, oh my goodness. And then the gentleman is tax number 3, Mr. Mugambi, number 4. Oh my God, all gentlemen. All right, we'll start with her. Let's give her the honor. And then who counts?
Miss Mami. Good morning. My name is Immaculate from Citizen TV. So my question is, when will the deductions begin? And how will they get contributions of the self-employed people? Thank you.
Thank you. I think connecting to Mheshimiwa, in relation to realization of universal health coverage, one of the biggest burden that is with the the common mwananchi. And Mheshimiwa could attest is that kule mashinani, every weekend is doing a fundraiser towards treatment of non-communicable diseases like cancer and other things, which now when it comes to issues around, of course, the NHIF itself, you find that it cannot cover up to a particular level. How is SHIF prepared? Because we are talking about access to universal health coverage to everyone. How is universal health coverage, or maybe SHIF, prepared to cover those very high cost of non-communicable diseases, especially to the very low class people, of course, who are not able to do the medical coverage and the rest, which has been a serious problem even to even the politicians there every weekend doing Arabis to raise money to go to India and other things and the rest. Thank you.
Thank you to the presenters, Mheshimiwa and team. I just want to make an observation, maybe a comment and a question. Mheshimiwa talked about digitization. Now, we know digitization is a big driver to achieving UHC. So my question is, one, we have the Digital Health Act. And within that act, we have the Integrated Health Information System at a national level. And there's a lot going in that space. And so we have the SHIF here, and we have systems. So I'm wondering, in terms of implementation, and maybe this alludes to the whole issue of transition, how are the two going to marry? Because if you look at the SHIF, and you look at the Digital Health Act, and you look at the primary health care, they're all riding on a digital platform. But then you find these acts and different agencies being autonomous. So I just wanted one to acknowledge Mheshimiwa's in terms of, it is very important to look at digitization as a driver to achieving UHC. But then as we do this, I think they should be speaking between the different acts. Then we have the Facility Improvement Act. So from a transition point, I guess it would have been nice to kind of have a committee or something for that. I'm just throwing these out and acknowledging that we really, really need to ride on digital health, which was missing from the data report when we looked at how do you access health services. We've seen clinics, private, but we again are not acknowledging digital health. Thank you.
Thank you so much. I'll come here, and then we will have the responses. Then we'll take another round. Thank you.
Good afternoon. My name is Ben. I work with K24 TV. Daniel from the NHIF, I'd like to know, number one, the means testing equipment, or tool, rather. Looking at a practical situation, for instance, somewhere in the village, you come across this widow who lost her husband, say, last week, and the husband left behind a 4-bedroom house, fully furnished. What is your means testing tool going to charge this widow with if she's unemployed? Is she going to be forced to meet the same rates that the equipment and the house puts her at, according to your tool? Number one. Number two, those in the informal sector who your law states that the government will have to pay the annual contribution for, is there an interest rate to that annual contribution being made by the government in the name of the Fuliza or the loan being granted to these individuals? And when it comes to the end of the year and this person is not able to pay back the loan, as Dr. cited, are there any penalties that are going to be, or rather this individual is going to face, or any fines to that particular effect? Thank you.
Thank you. My first question is to the representative from SHIF. What mechanisms are there to ring-fence contributions from citizens? Because whereas Dr. Lishengas alluded to, this fund enabling the fund to pool more resources, the president himself has alluded to the fund being a pool from where they can borrow. When he wants to hire a jet, for example. And with the political board that Dr. Lisheng alluded to, you know, when you have a board, your voice cannot be heard. You are nobody. So what mechanisms are there? My second question is, what would stop a hospital, knowing that everybody is covered, from beginning to treat even non-existent ailments because there's money? And we've seen that happen with the Nairobi women. So long as you have cover, they start, you know, imagining that it is too early to discharge you. And even if you are not going to access private health, we have public hospitals with private wings. Kenyatta is an example. So what would stop people from being enterprising and imagining how they can, you know, benefit more from the pool because everybody is covered? But the last question is, and which is one of the ugliest that Dr. Lishenga didn't point out, is that if you're not covered under the fund, you can't access other government services. And of course, it's under contestation in court, but I think the court is here to pronounce itself on it. That you've been raided by thugs and you are reporting to a police station, they say, where is your SHIF card? You can't record a because that's a public service. There's a public participation by county government and you are saying, no, you can't participate. Where is your SHIF card and so on and so forth? So those are my concerns. Thank you.
All right. Thank you so much for that round of fast questions. All right. Then let's allow Mr. George to take. And then, please, allow me to extend this. We will also take one question online, and then we'll close that, okay? And then we'll open up Tena.
Okay, thank
But
you.
let's keep it short, please, so that we have more questions from everybody.
So thank you very much. I had said earlier, I'm George Awala. I work with VSO, and we have an interest in health, especially as it pertains to health of vulnerable groups like persons with disabilities. So I really want to get your perspective. This is going to the SHIF representative. How will you do the assessment? How will you ensure that these persons with disabilities or the vulnerable groups get the support that they need? Because sometimes it's beyond the normal support that's required, and that it's also very specific to the individual, because now we are also looking at intersectionality, where you are delivering programs on the basis of an individual's unique identity. Then the second one, linked to what Churchill has talked about, how will citizens hold the government to account on the SHIF funds? Because that's a worry that every Kenyan has. Thank you very much.
So much. All right. Let's pick the last question for the first round from online. Jane, please, I cannot see online, but whoever has their hand up, please allow them to speak.
Thank you so much, Sarah. So we have two questions. I'm not sure if they want to speak, or I can just read the questions from the chat.
Go on to read. Jen, read, please.
Okay.
Thank you.
Okay. Question number one, why is it necessary for the current NHIF members to register for SHIF? Does it mean NHIF does not have the correct information? And then the second one, so he starts with some sort of a comment. For Daniel, to suggest that people can take loans to pay for SHIF proves that this system is not feasible or accessible to the target group. Is it okay for a system to propagate debt burdens? In brackets, he says that can be avoided through better planning to its citizens without worrying about the ripple effects to wider development? Those are the two questions. Sarah, over to you.
Thank you so much. All right, so back to you. Let's start with Mr. Daniel. He's already on the stage, and then we'll have Dr. and then we'll have Mheshimiwa, right? Thank you. Over to you.
Thank you. I hope I've captured all the questions raised. I think there was one from Immaculate. on when the deductions will commence. On a light note, I think I watched Citizen, and I saw in the news the CS announced that the deduction will start in July. So unless that has changed, on a light note, I hope we will not be offended. But yeah, we're expecting from July the new deductions will kick in. The other one, this is from Mheshimiwa. Okay, the other one for me was, this was also from Mheshimiwa, but I can comment on the digital. There was an issue, I hope the other panelists will also comment, but on the issue of the Digital Act, I hope you are aware there is already the Digital Health Agency in place, and they will spearhead the digital health superhighway, so they will be able to coordinate everyone in the health space. And I think that should be tied with the issue that was raised there of fraud. Someone was asking whether people will not cook, they are treating fake patients. I think with the digitization, it will not be like before. It's an vision that any doctor should be able to see your health records across the board. So it will not be like before, where you come to me and I don't know your health history. So whichever doctor you visit, you should be able to access your health records, and I believe that should minimize that issue of fraud and treating fake patients. Then the issue of the main testing, the way it has been designed should be able to adjust to some of those changes. Then the issue of premium financing, I think this has become, I didn't know it was going to be an area of interest, because these are an optional facility. It's not like it's part of the requirements. So it's up to you to decide. It's optional. So the issue of whether you need it, it's up to you to decide. You don't have to utilize premium financing if you're not comfortable with it. Then there have been issues of, there's the issue of ring-fencing contributions. I believe SHA will be reporting, of course, their reports which go to the Parliament. So that should provide some oversight on its operations. Then the other issue which I can comment on is the PWDs, how they will be assisted. I think, as I mentioned earlier, the main game changer of this new model is the focus on primary health care. And you know already we have the CHPs, which you mentioned earlier, who should be attending to specific number of households across the country. So with that kind of personnel on the ground, we should be able to identify these special groups and how to address their needs. Then then the other one is, I think from K24, why NHIF members have to register. Why do they have to register? I think this is part of also what was prescribed in the legislation and also the regulations, that SHA has to register its members afresh. So that's a requirement by the law. So I don't know whether I've left out any of the questions that were directed to me. If yeah, that I think I mentioned when I said it's part of the premium financing. So that's what I said. This is not a requirement. So you don't have to. It's just an option in case you need. So I don't want to be misquoted that you have to utilize premium financing. You don't have to. So it's just an option that will be provided for whoever feel that they need it, but it's not mandatory.
All right, thank you, Mr. Daniel. I think we'll allow you to sit down for now, and then we'll take the last one. But Dr. Brian Karibusana, please take on the questions that you're able to, and then we'll hear from Mheshimiwa and take a last round, final.
I don't think there were so many questions directed to me, but I want to comment if anything can be taken away from this, my discussion today is, first of all these things are already law, and this is our reality. This is how we are going to exist for some time. So I don't want us to take the perspective that there's anything changing. Nothing is changing. This is a reality. But now that is the situation, I just want to send Mulinge back, but also through the media to convey the most important point here, primary health care. I do not think that we as a country understand how important primary health care is. There is lip service being given to primary health care, and I don't like when Mulinge says that that is the game changer. There is no game changer there. I will explain why. You cannot say, and with all due respect to CHPs and CHVs, they are a valuable contribution. But you cannot say that since we have 100,000 CHPs, you have changed primary health care. This is crazy. As a doctor, I rebuke that. It is not the way we are going to go. That is number one. Number two, on primary health care, Mr. Mulinge, you used to pay us 1,200 shillings to take care of one Kenyan for a year. You guys don't know that, but let me tell you as my fellow citizens, when you go to a hospital and you say, oh, sina dawa, you are telling a hospital that has been paid 100 bob per month to take care of you. That is the reality. That primary health care was 100 shillings per person per month, which translates to 1,200 per year, which was being paid quarterly. So wewe ukienda kwa hospitali useme pesa yangu iko hapa, wewe unaongea juu ya saa tatu. That is the money you are talking about. Now, let me just, the reason I'm telling you that is where we are coming from, 1,200 per annum. But here is the ridiculous thing, that in the current proposal, they are actually slashing that to 900 per annum. You get, for primary health care. And then not only that, there's a proposal to limit the number of Kenyans who can be assigned to a hospital. So the hospital is getting 900 bob from 1,200. But not only that, there are fewer people assigned to that hospital. So the hospital has less cash. My biggest concern is that we are saying primary health care is important, but we are not putting money in primary health care. We need to put money in our level 2 and level 3 facilities. Do you remember when I said we had 250 billion, 140 billion was going to SHIF, isn't it? Social Health Insurance Fund, which is operational at level 4, 5, and 6. 50 billion is what was going to primary health care. That should have shocked you, because we are taking where people go every day. Because today, when you become sick, you will go to a primary health care facility. We are giving them the least amount of money. And not only that, in the current budget policy statement, they have even said we will allocate only 4 billion. So this, my statement here is twofold. One, to Mulinge and say, please go back to the SHA people and facilities. I dare say it is not 50 billion, maybe even 100 billion, something that will make a difference to the people of Kenya. Thanks.
Before he goes. No. Firstly, I want to commend Daniel for trying to, to put a bright light. We need more civil servants like him. But he has apparently bitten off a bit more than he can chew. He doesn't have an idea of what the Ministry of Health has in mind. And NHIF, as I said to you, Daniel, please take it back. Here is a very, very simple thing. Elijah Washira, we wrote to you 3 weeks ago. I have 12.8 million shillings waiting to be given for the 2,300 of my applicants. Tutatuma wapi je? You haven't answered. Now if you can't answer that, how are you going to now implement the other issues? So firstly, as far as Kisumu East, answer that very quickly. It should have taken 24 hours for you to answer it. So please go back to the Chief Executive asking. Kisumu East is asking, where do we send the money? And we also want a written understanding, a written agreement that that money is going to be held under the social SHIF or SHAF or whatever, or shaft. And will not be shafted later on. So that was the only thing I wanted to bring to his attention. So may I then talk about the others? You see, the health scheme that has come to Parliament is a policy document. Legislation is policy. It tells you what is accepted. Thereafter comes the implementation from the agencies, Ministry of Health and others. NHIF falls under a different scheme. I don't know what they call them, parastatals or whatever. So they themselves have to then provide through the Ministry of Health, who the CS is now everything, how they're going to implement. The first thing I want to tell you this, implementation is a critical factor. And you as the service provider are going to be hit by that particular issue. So any help we can give you, we are very willing to do so. Second point that was brought up by my friend Churchill, you cannot, under the present system, ring fence the funds that are being collected from SHIF. Remember the Public Finance Management Bill, which says all funds collected must go into the consolidated fund. Yes? Let's not fool anybody. It goes into the consolidated fund. It is not ring-fenced unless we are able to ring-fence that. And remember what happened to the funds for the Northeastern, what was it called? Special development for Northeastern. It was never ring-fenced either. So here we are going to receive millions and millions of shillings into the consolidated account, not to the NHIF. Sorry, Mulinge, hear me please. That money is not coming to you. That money is going to the consolidated account. You will then be paid out of that consolidated account a certain amount to be decided by politicians. Next part, there is a Maputo Declaration to which we are signatory, and we must comply. We haven't complied for it, how many, 25 years? Which says that between 15 and 20% of your budget must be dedicated to healthcare. So we have a problem there. Yeah. Yes. Yes. Okay. Daniel, please come and say what you would like to say. But tell me about the ring fencing. Huh?
People do not want you to leave. They still have more questions.
I'm really Shenga has also enough information. I don't know whether any burning issue, because I think I have, you know, the challenge, okay.
My question is on based on what we have had in this forum, the question and the findings of this survey that was reported here.
Yes.
To what extent is the current act, SHIF Act, as currently enacted, based on evidence that it can work, or it is working somewhere? Has it been implemented in any other countries, for example?
My question is just, I have two questions. From all the discussions I've had, I've not had the touching on the issue of quality assurance. How will the fund improve the services or the health services provided in this country? Because we already know we had the NHIF, but even the hospitals were supported by NHIF. The quality of health services was subpar. How will this fund improve the quality assurances? Number two, I work for County Assemblies Forum, so I have to bring this up. It becomes the issue of sensitization about SHIF. For me, I represent the members of County Assembly, who are the lowest, or we could say the smallest unit of governance in our country. And these people, the public depend a lot on the MCA to sensitize them on informations, on issues of to do with national policies and laws. What measures will you take to ensure that there is sufficient sensitization about this SHIF to the wananchi who is at the ward level? Okay.
Okay. My first question is on the elderly, that is above 70. Currently, they are supported by the government through the Inua Jamii scheme. We all know that, Cindy. So first, are they categorized under the informal sector? And if yes, it means they will have to contribute the 2.57%, right? Where will this 2.75% come from? Will it be captured from the, or will it be reduced from the Inua Jamii scheme that they're enjoying? Where will this money come from? That is number one. Number two, it's on the youths who are categorized under the informal sector, those who don't have jobs. We all know how these informal sector are unpredictable. You can't predict. Are there penalties in case I don't render my contribution? That is, maybe this month nimepata pesa nikalipa, but now the next month sijapata. And if yes, kuna those penalties, they're capped at how much? Secondly, still on the unpredictability of the informal sector, how will you people keep tabs on the faithfulness of this 2.75%? Then, in case one retires, what will happen to this individual? For example, I retired when I was capable of paying maybe 30,000, but now I've retired. What will happen? Then lastly, during the Magoa era, I think students were enjoying free medical treatment at schools. Will it still continue, or with the new emergence of this new scheme, measure? Then lastly, students below 25, that is now from 18 to 24. What happens to them? Thank you.
I know you have a question online. Please allow us to reserve that for Honorable Shakil and Daktari. Thank you.
Okay, thank you. Maybe I can start with the last, going back. There is the issue of students, which I think it was explained earlier by Lishenga, that they will still be under the armpits of the household. Then there is EduAfya. EduAfya, I believe we are all aware, Eduafia was discontinued. Okay, Eduafia is. I mentioned when I started that NHIF is no longer, or rather SHA will no longer be engaging in enhanced scheme, because for Eduafia it was an enhanced scheme where they were getting premium benefit. So SHA will not be covering those or running those kind of schemes. The issue of penetraries, I can't recall the rate, but they are I think they are moderate. But normally the penalties, they only apply when you were late and you want to use the card. All right. Then you ask, there is a question I didn't get clearly on the issue of keeping tabs on the 2.75. What did you mean? Okay, I get you now. I've gotten about the question. So I think those are some of the challenges. As I said, any shift in policy, there are implementation or rather teething problems, because clearly you cannot do MT every month, So that will wait until the next cycle when you are assessed again. Because if you change, yes. I said I've understood your case, and I've just mentioned to you, you cannot be able to undertake this exercise every month, actually, isn't it? Yes. So I think I'll combine. There is a question which was touching also on the issue of indigents. And the indigents, we know, those are the poor of the poor, those who are not able to pay for themselves. So still, the government will have a mechanism through the social protection to identify those who are not able to pay for themselves. And previously, you are aware, even their counties and also the national government, it's the same program, the way someone has wrote. Is it the same question you had asked about in Wajami? Yes. So that program, again, is not there, but they will be assessed. Those who fall under the category of indigents, again, the government will have a mechanism where they will be paid for. All right. The issue of sensitization, yes, I agree with you. There has been a delay in terms of information flow, but within the month, you'll see a lot of activities in terms of trying to disseminate information and making sure that everyone is brought on board in terms of what is happening. There is a robust program on how this information will be shared. The issue of quality assurance will not be handled by SHA. There are other bodies under MOH which will deal with the issue of quality assurance. So that will be a separate agency handling issues to do with the quality at the facility level. Then quality, sensitization, the elderly, we have handled that. Youth, we have handled payment. So I think I've handled all the questions. So in my closing remarks, I just want to thank Taweza. This is part of those engagements. And we were not supposed to, we were just supposed to participate like you. Otherwise, I would have been given an opportunity to also come with my PowerPoint and share the information. But going forward, we are going to have engagement. We'll also share with Taweza, those who are able to join some of those forums, you will be invited. For me, I just want to say thank you for the opportunity. Again, I want to say this SHA, SHIF, it's not about us who are in SHIF or who are in SHA. I think this is an issue for us, all Kenyans. So I really appreciate this engagement. So even me, I want to benefit as a Kenyan. Even the same questions that you are asking, I have so many of my relatives who are asking the same questions, and I also want them to benefit. So I want to say that I'm encouraged by the questions, because as a country, this is a serious shift from what we were doing, and we are really hoping that it's going to work, because if it doesn't, I mean, we are all in. It's not that I'm defending because I'm probably getting my salary from NHIF, but also as a Kenyan, I have also family, I have friends who I also want to benefit. I think Lishenga mentioned something which he didn't drill into, catastrophic expenditure. You know, you have one sickness, proper funding. If those who are from the county, for the longest we have been pushing for county facilities to be well equipped, enough personnel, because that's where, you know, okay, I don't want to go into details, but if public facilities were working well, we are not saying private sector should not have their share of the business, but I still believe the success of this model would depend majorly on how our public facilities will be equipped, both the personnel and commodities and otherwise. So that's an area. Those who are in county government, make sure that your facilities are working. And no one minds going to anywhere where you get quality. Doesn't matter whether it's a public facility. So if the facilities are working, I'm sure that this will work. But so long as we have the same issues, no medicine, you go there, even the personnel, no one, again, we will be stuck. So my parting point is that we are all of us in this. Continue asking those questions. Ask the right people. I don't mind being asked, but I can still say some of those questions are beyond me, just that I have the information. You know, these are decisions which were made. But again, for me, it's for the country. So let us question the way we are asking and push to make sure that we get the best. Because anywhere you are putting money, again, you expect, you know, to get value for money. So thank you so much. I'm sorry I have to leave. I would have stayed. If there is another forum, I don't mind coming. And I'm sure most of the things by then will have crystallized. And we should be able now to even engage from a very well-informed position. Thank you so much.
Thank you, Daniel. Some coffee for Daniel Jamani. He's really tried. How are you guys feeling? How are you feeling? Like really feeling, the gut feeling. Stressed out, upset, angry, shocked. I think we have gone through that 5 process of grieving, denial, anger. I think everybody in the room has gone through that. But we will, I'm sure we'll reach. Now I think we'll bargain and then we'll start healing. So Daniel, thank you so much. Tumeshukuru sana. We will talk. So again, jamani, some coffee just to say thank you to Daniel. As Daniel said, Dr. Lishenga said, it's a reality. It's mtake msitake. Come July, pesa mtatoa. Kama mtafuliza, utauza shamba, utauza, yani utajua mwenyewe. Lazima ulipe. Sijui kama alafu mheshimiwa ametuambia hapa kwamba hatuna uhakika kwamba utapelekwa polisi, manake mimi tayari nina wasiwasi. Sasa manake mimi when you talked, I said anyway, if I don't pay, the maximum they can do is throw me out. And then I heard when I go to a police station that I can't get service. And Mr. Suba said that you can't get any other public service. If I lost my ID, I can't get. Now I'm even becoming worried. I'm wondering this enforcement of mandatory, some must, forceful, how, you know, in the long run, how it will be. Mheshimiwa, please, I know we had cut too short. Please, karibu tena. People can stretch a bit if they want, while Mheshimiwa is giving some of his submission.
Thank you. As I said, if I was the chief executive of SIF or HIF or whatever it is now, I'd be proud of what Daniel has tried to do. because unfortunately, it's something that he has very little control upon. Now let me go back to one thing. Vision is a dream. Mission is where you're going. Implementation is how you get there. Vision without implementation is hallucination. Are we hallucinating here? One thing that is very clear, you asked me what we were doing when we were looking at that bill. It is clear to me that the aim, you see, the question is, what is SHIF or NHIF? What is it? National Health Insurance Fund, or else Social Health Insurance Fund. What does it mean? Means there is a parastatal somewhere which has got a fund. Am I right? Full stop. Is a body which has got a fund. Question is, has it got the sufficient fund to create the services that is promised the insurance holder, that card holder? Yeah? That's the question. Is it the government? No, NHIF is not the government. SHIF is not the government. Is SHIF part of the health ministry? Is it? They've got their own board, huh? They report separately. It comes to us in the finance committee and the health committee. It doesn't come under the NH and the health budget. Do you understand what I'm saying? What is clear here, and Daniel has tried in his way, PHC, primary health care, game changer? No. Changed any game? No. The situation is, when we as CDF were building healthcare centers, health centers, about 7 of the health centers that I built in Kisumu East, and I'll give you by name, are more or less closed. Primary health care is a devolution responsibility. They're closed. So, what is here? Remember he said there are going to be 3 elements. Primary health care, then the SHIF, then what we call serious diseases or whatever, remember? And he said primary health care, and you know it is devolved government. Churchill, remind us, isn't it devolved government? It is. Serious health, level 5, is now national government and is going back. So what happens? You SHIF are each side of you. There's the devolved government sitting here. There's the national government sitting here. And inside here you are the social health insurance fund. You're responsible to that person who's paid your social health insurance premium. Do you understand me? Now you're going to tell us, you're going to tell them to go to the primary health care unit. It's fine. Will you pay the primary health care unit to serve that person? Never said so. You go with your NHIF card there or SHIF card to the primary health center. Unapatiwa aspirin nini. Unadese, toa pesa. You have no money. Here's my card. No. We don't take your card. Okay. So you go to, you're in Kenyatta and suddenly you've got cancer. You go with your SHIF card. But it's not covered here. Hii sasa ni serikali, national government. So you go to Kenyatta. Kenyatta says, okay, hold on. Tutajua, let us put an application to the ministry. So there are 3 systems here. Huh? 3 systems here. They should be interacting. They're not. CHVs are to be paid by the devolved government. Devolution. They are having a difficulty in paying clinical officers. They're going to pay CHVs. there are 150 CHVs that come to my office. Yeah? I personally pay them. Personally. You ask me where my mishahara yangu naenda. 2,000 shillings a month. Politically, they are very good for me. But they're 2,000 shillings, anasema hakuna nini, hakuna, we don't have gumboots, we don't have this, we don't have that, we don't have that. Do you understand what I'm saying? The thing is falling apart. So we have to come and say, okay, fine, NSHIF, let's go on. Whatever it is, there is an act. You are going to pay your 2.75%, but it's not going to work. Who's going to collect it? The county government is collecting on your behalf. Kenya Revenue Authority is collecting on your behalf. Have you got agents going around to collect on your behalf? And what is the law? Health insurance fund. Any health insurance fund is a voluntary deduction. It's a deduction. You understand me? You don't pay, you don't get served. Here we are saying it is going to be mandatory. What is mandatory, my brothers? Taxation. This is tax. Call it what you want. It is a tax. And where does the tax go? Tax goes to the consolidated fund. Let's be blunt about it. And it's not going to be ring-fenced. And at the end of the day, somebody, including myself sitting in Parliament, is going to look at the budget, and we're going to say, how much do we collect for this fund? And where is it going to go? Do you understand me? Is it going to go to, as Churchill said, some special expenses? We have also the unclaimed asset fund. Ideally, we have been trying, you know the unclaimed asset fund? Billions of shillings. We are trying to ring fence that fund. And when Churchill, you might want to look at the unclaimed asset fund. That's where the 200 million came out of. Yeah? 200 million came out of there. It is unclaimed asset fund. There's the stolen asset recovery fund, the illegal asset recovery fund. It's also got money there. So the question really is, are we going from the known to the unknown back to the known? No. We are going from the known, as bad as it is, to an unknown. We don't know where we are going. Yeah? So the point is this. Can we crystallize on our strengths? NHIF, this is the strengths. This is a great document. You've put in the requirements and what people think about. Let us go back. Policy and the act is the act. And he just told you, we are getting implementation notes. Implementation notes are to be worked with the ministry, to be worked with at each level. Believe me, and I've been in Parliament for 4 terms, my friends. I've been in the Finance Committee for 3 terms. Believe me when I'm telling you that these funds are going into the consolidated fund. And believe me when I'm telling you that it will not come, all of it is not even part of it. Even 15% of it is not going to come back to the Ministry of Health. No. You know, it's a reality. You know, we as the tourism, the Ministry of Tourism, and I used to talk about it. Is the ID, digital, for another country. It was budgeted for, it's a European country. She goes, and this is the digital person, it's not a real person. Goes anyway, puts it in, read, information given at any time. We have that capacity. We are doing Safaricom. And as I want to tell you which committee I sit on now. I sit on the digital committee, yeah, communication, information, and innovation. That decides on we are going to digital recording and digital everything else. That's a major problem. We're trying to get this thing sorted out. Our digital systems are 24 years old. Remember what happened to WorldCoin? So what happened to where's the information? In a cloud. Where's the cloud? It's not here. Oh, sorry. Oh, thank you for the money. Oh, it fell down. Thank you. What I'm asking, where is it in the cloud? As you know, our Navasha cloud is a junk yard. Now we are going to go and get another cloud from America at so many billion. A storage center for cloud costs minimum of $1 billion minimum. $1 billion. We went to South Africa to see this. So where is our information of the world coin? Because it meets with this one. If you've got a digital information system on your health, it would be somewhere, right? On which cloud? So we went to go and see this. Do you know, some of our members actually asked the question, jokingly perhaps, or I don't know. We are going through this cloud. Do you think it will in the plane, will it disturb all the information that is in the cloud? Now this is where we are coming from. A cloud is not that cloud, my brothers. A cloud is somewhere. You know this thing here? That place where we went to go and see, over $1 billion worth. We asked, where is the information? They looked. You see that little stack there? The stack was less than this size. Yeah? This size. In that stack, you see 2 or 3 servers. It's in one of those. What? It's there. Who accessed it? Whoever put it in. So can we find our information on Iris? Can we get it back? No. WorldCoin put it here. They have to tell us to give it out. Then question is, what if you lose the information? They say, no. If even there's a world war, it's an earthquake, no matter what happens, for 30 days we have information. Nobody can affect. You should go and see that place. Shock-proof, everything. And then if the moment there's a problem, it sends it all over the world. Do you understand me? So that information is elsewhere. We have no control on our information. That's the point. We have no control. So soon, if we don't have this, all our medical records will be in the hands of those companies that are selling drugs or making drugs. We have no control. The other day we were just talking. Do you know that there is a treatment for AIDS? In certain countries they're given that treatment. You know that, Dr. It costs $30,000. 2 doses. $30,000? 2 doses. That's it. Memoriza. $30,000. We've been trying to see how we can make that into generic so that sisi watu wa Kenya na want to faidike. Do you understand me? Are they going to give it to us? No. $30,000 to shot. How many are you going to do? Maybe Zuma and 1 or 2 others, but we're stuck. So I believe me, as a member of parliament, I'm skeptical. I'm asking, can you accentuate the positive? Can you please just concentrate on what we have? Let's not give big stories. Just assure us that whatever we're getting in NHIF, we will get in SHIF. That's the only thing we're asking. I have a letter and I'll send it to you. The CEO has not yet been able to answer that question. I sent that letter to him 14 days ago. Why is he not answering that question? Because he does not know what to say. So we are stuck. Do we send the 12.8 million shillings? That is the 190's money, not 12.8. 2,300 by 6,000 is, no, it's more than that. Do we send that money to NHIF, which Dr. has told you is a dead body, is a dead duck as of July 1. And it's going to be put in what is called, what is it called? Bills, outstanding bills, pending bills. Are we going to send our money there? Or are we going to send it to SHIF? Is SHIF even registered as a body? I don't know. Do you understand me? I'm telling you a simple, straightforward question. You are asking about where your premiums are going to go. Here is a straightforward question. Where are our premiums going to go? Can you confirm to us in writing that they are not going to be lost in the NHIF? Let's say I send it all to NHIF. July the 1st comes, our people with that card. Nasema, NHIF wanaenda kando wana huko, pale, pale. No, but we pay it for the whole year. Any NHIF enda pale. Sisi tunataka SHIF. This card does not show SHIF. I just showed you my card. If I pay, I want them to issue us SHIF card. They have no capacity even to offer us, give us 2,500 SHIF cards. Do you understand what I'm saying? So as much as you've done this work, as much as I am what we call the negative, let me see that, let me be that way. My only question is, I am negotiating and talking to the chief executive. My dear brothers and sisters, you can't get where I'm getting. And if I can't get that answer, how are you going to get it? How are the Wananchi going to get it? Where are they going to stand if we don't stand with them here and now? Thank you.
Thank you, Mheshimiwa Shakil. You decided to be the devil advocate here, which is good, you know, to just pull the bandage, the plaster, you know. You don't have to do it slowly. We have to face reality. And going back to what Brian mentioned, Dr. Lishenga, that it's our reality. This is going to happen. So I will not even ask us to ask more questions. To me, what I want us to do now is this floor, including Mheshimiwa and Daktari, for us to suggest what do we do. Kwa sababu ndio tushafika hapa. Yaani hapa tunasubiri mtoto azaliwe tu. Mabeseni sasa tufanye nini? Tujitayarishe kununua mabeseni, sijui pamba, sijui nini, ndio naambia sasa. Sasa hapa nataka sasa tuchanganywe kichwa, tufikirie, tufenyeje. Because we have to do post engagement. We have to. Lazima tujiandae. I think you mentioned kwamba Waswahili wanasema unajiandaa kisaikolojia. We have to prepare mentally. Asa nataka my desire is in this floor today kwamba tutoe mchanganuo wetu. What do we do? Suggestion. Because we do want, as Dana said, we do a lot of engagement, post-engagement with we met with the health committee, the transition team for SHIF, and we want that. Mimi kama nyinyi, kwa sababu sisi wote ni wanaharakati and we are stakeholder in this, kwamba tupeane mawazo yetu, tuyaweke pamoja, alafu tuwapelekee wahusika. Kwamba it doesn't mean that hii issue inaisha hapa. We have to follow it. We have to follow it. Whether isha kwa sheria or not, sidhani kama kukata tamaa is an option. We really have to follow it. Alivyosema madam pale, what happened to mama mboga leo unapata 500, kesho unapata 1000. Ushaambiwa utajua mwenyewe. Upate 500, upate 1000, kulipa utalipa. So ndio tuko hapo. Online people, someone asked, yeah, I'm already vulnerable. For me to take Fuliza, it means I'm vulnerable. Tena bado unaniambia tena nichukue Fuliza nifanye matibabu. Kwa sababu when you are sick, you're already vulnerable. And then you're telling me to take a debt. Because when I'm sick, it means I can't, kama mimi ni mtu wa mjengo ama mtu wa kazi za mkono. Na mimi siwezi kwenda kazini. Sasa hiyo ile ya kulipa hiyo Fuliza mimi nitaitoa wapi? So I am going to, Sarah, to the floor, to come up with some of suggestions which probably we can put together if it's to do a memorandum of understanding, or if to to have something, a press release out there, or also share with various policy maker. But I think there have to be some resolution which comes from this particular discussion, and we also hope Dr. Lishenga and also Mheshimiwa Shakil will also propose. I know there are some suggestions during the discussion, but now is to fine-tune them and to crystallize them much better. To Sarah?
Right. So anybody
Betty, and then we will allow Dr. To make final remarks, and then we'll wrap it up. Please, apologies for taking too much of your time, but allow us 20 minutes, we'll wrap up, and then we'll have lunch together. So where do we go from here? That's what Melanie is asking. A few hands, and then we can give it to Dr. and wrap it up. Betty? Right. Any more hands, please? Where do we go from here? This thing is here.
Hapana, you have to say something. Sana maswali mulikuwa mnaambiwa mkono asa mnaambia what do we do? Kila mtu anashikia ama ndo mmepata mshtuko? Ha? Moyo unapiga. Mnasikia njaa. Umeona mzee amesema ukweli. Kutoa makosa tunakuwa wengi. Wenye kuona kukosoa tuko wengi, lakini sasa kusema atufenyeje kila mtu ananyong'onyea. Inakuwa kila mtu ana. So there's Betty, and then I think is there any other person? Yes, ma'am. So the third person, tuanze, I'm sure. Watu watachangamka.
Please keep it short so that we don't go over 20 minutes.
All right, thank you, Sarah. I don't know who I should be addressing this to, but I would like the both of you to maybe answer me. Article 35 of the Constitution is very critical so that we can be able to participate meaningfully in accordance to Article 1. I feel that the law, the Act, was not well brought to the public so that they can exercise their power, because power belongs to us, the people. And it is very unfortunate that we exercise this power just 5 minutes when you're giving it away at the public during voting. So now that I am here representing Bunge Mashinani as Mama Mboga, I don't even know what Mama Mboga, if Mama Mboga understands this. So how then do you make it a law without the citizen, the real owners of power? How was it enacted as a law without even having the people participate? And what can we do? Can we repeal?
Thank you, Betty. Right. All right. That she put a question, but also kind of a suggestion. Thank you, Betty. Let's have.
For me, what I think is really important, also recognizing that the right to access to information is a very key constitutional right, is that as much as we are seated in this room, for us who have been exposed to what the bill provides, what the regulations provide, until Mama Mboga elewe kila anaambiwa, which I don't think there's so much focus being given on it. There's so much rush to pass this act. There's so much, we need it to be, we need to tax you, we need to start remitting as early. That is not the most important aspect of this SHIF or SHAF. Because I can give you a case of example. When the Constitution was drafted, and there was so much clamor to pass it, I can tell you, hakuna mtu hii Kenya akuwa anajua hiyo constitution inasema nini. Si iliandikwa na Kiingereza na Kiswahili, ikawekwa kwa newspaper. There were books everywhere, there were documents, there were newspaper, there were discussions from morning to evening that this constitution will provide Kenyan citizens. That is a case example of an intentional step to sensitize Mama Mboga. So I would propose that, does it mean the Ministry of Health has to partner with the CSOs? But the sensitization must happen. It has to reach the ward level. From the northern parts of Kenya to the smallest, I don't know where, but to the south coast, people have to know what is in that SHIF, especially if you're expecting people to remit. The public confidence or the trust after NHIF is very low. Of people, of the public is very low. So I think that would be a good position to start. Yeah. No, yeah, I'm done. I'm done.
Thank you so much for this opportunity. And I think my issue was around sensitization of the consumer, because it looks like there's a product that has to be bought, let's say by me, but then I don't know the product. So just adding on what my two other colleagues have said, it is critical. But then, what is the point of having a new registration when we have a system in place that NHIF is currently using? I think that is critically important, that we don't reinvent the wheel. It will take resources that already we don't have. We are far below our budget allocation. In fact, the budget for healthcare has been slashed by almost like 5 to almost 10%, which is really critical. Health is a right, it's an essential service. So, you know, just having a budget for registration and not a budget for service delivery speaks volumes to how we do things. Number two, in the spirit of digitization, because I looked at the document and has, you know, the digital health aspect, how are our health workers prepared to implement the same when we have a health worker at the lowest health facility, let's say level 1, but even at level 6, who is not able and does not have basic computer skills? And these are the people who are enablers. They are supposed to be the people who enable the system to work. How then are we preparing them? How are we capacity building them to be able to effect the system without any hitches in the system? Thank you.
Yeah, I acknowledge I live more informed, but again, more discouraged than when I came. I mean, it's very disheartening to imagine that we had people, we voted in parliament, they passed this bill, it became a law, and I wonder whether they know what they passed or they were just sent out of the parliament, those that could oppose. So I think it's a point for us to consider when we are voting. But again, it's late, but I think there's still much we can do. I would ask the media houses if they would hold, like yesterday, Citizen kept us following the bill on, the recent, the finance bill. So I wish they can do more of that so that more people, especially on this particular bill, more people can come on board. And we can ask our MP if we can lobby also other like-minded MPs, so that at least even if they are going to do it, it's too soon for July. Can we be sure, from what I've heard from person representing NHIF, they have not even put down the structure. Like he's asked a question on structure, he just avoids it. What is it, how their preparation has come. So can we ask the MP and even Taweza and others to lobby more MPs so that they can hold at least more discussion, to have this waited until they are sure that NHIF has put the structure in place. I mean, they have what it takes for them to operationalize it. Yeah, not just every time thinking of how we are getting money from Kenyans. So my take is media and also the parliamentarians. What is it that we can do to help the Kenyans? Even if it's going to be rolled out, systems are put in place.
And then Joe will come to you for that comment.
So thank you. I'm Emmanuel from Bunge Mashinani. Mine is just a concern. I heard Daktari complaining that the CS is the one who has become the decision maker in everything. Yet when it comes to paying these taxes, you come back to us without a public participation. So I think what we should do is everybody should respect the Constitution and allow power to be exercised to the people. And the other thing, are MPs understanding this bill, or they are just following what they are being told by their bosses? Thank you. And we are the bosses, not the president.
That's a good reminder. The citizens are the bosses. Okay. And now that we could have a debate over the whole day. Right. Jen, would you read that comment, please? Are you able to hear me, Jane?
Thanks, Sarah. We actually have two. Yes, can you hear me?
Yes, yes, please go on.
All right. We have two comments. Sawa, I suggest that through this platform, a policy brief should be prepared with strategic issues to lobby and advocate for a better healthcare system to be put in place. And we have the last one. Have the capacity to lobby, mobilize, and store the implementation of the SHIF, given the grants we have of the new fund. We cannot be a country driven by an appetite of resource collection without giving much thought on service delivery. And then he says, I like what Mheshimiwa said. A vision without implementation is hallucination. Thank you so much, Sarah. Over to you.
Jane, thank you so much. Last one.
Asante sana. I think I came in late, I'm sorry, but having listened to all of us, we're becoming a typical Kenyans. We always wait for the last minute and cry and whine. This act has gone through. If you go to SHIF, for example, I'm sure they have list of many people they've talked to as public participation. This act has gone through experts. This has gone through parliament. What we're saying here are all stories. I think what I want to tell us Kenyans, let's not wait for the last minute and try to pull something which is already kicking. For example, what's in the act? You contribute first, wait for some month, and get the service. Am I right, Dr. And we're happy with that. Parliamentarians are happy with that. You know, what we're saying right now will never change the act. Whether we like it or not, it will be implemented. So the citizen's voice never counts. So the only time when our vote will count is when the act is, when that proposal is in circulation before it goes to parliament. The moment the parliamentarians, which Mheshimiwa is here, has passed that and become the act, then we have less voices. I think what we need to do from here, I think this one is gone. For example, right now what's current is finance bill. I am very, very sure we will come back again after that act is passed by Mheshimiwa. We'll come to this kind of boardroom and lament again. Why is it this? Why is bread tax? Why is this going up? Let's walk up right now and talk about the finance bill to Aweza. Bring a forum to talk about the finance bill before it is passed by the parliament. But the moment it's passed by the parliament, then don't call people to this kind of forum. It's too late. So that's my comment. But actually, if there is a way, this can be repealed. And I'm sure we know Kenya. We are from this country. Once something is passed, of course, these are many stories. I know the repealing gets no there, but let's try and see what we can do. Let's leave the SHIF thing to work and see whether it will work for us. Let's work on the current finance bill, talk about it, see what we can change, so that we can know we should not come here and lament again. Thank you so much.
I am seeing heads shaking. Others want to say something in response to that. But I still believe that there's still a chance for us to do something, right? While it is being implemented, the regulations have been set, the law has been set, but implementation is coming, right? And that we will be here to stay and to observe. So I think it's important that we continue engaging regardless. But yes, it's a good challenge that finance bill is here. It's an opportunity for us to engage. It is an opportunity for us to raise our voices. So please don't be left out. Right. Now, Daktari, it's your opportunity. Please, you have had what is coming out of the room. You've heard what NHIF has said, what Mheshimiwa has said. Please wrap it up for us. And we have learned so much from you. please continue educating us as you bring that to a close. And apologies for taking so much of your time. Karibu.
Okay, so first to thank Twaweza. Actually, when I got this invitation, I was very hesitant. I gave her a lot of problems. But then I looked at the theme and what you actually captured it very well. Shifting to SHIF, was it shifting? And I was like, this is Mheshimiwa say shafting. No. So I immediately thought that this is a beautiful conversation to have. So kudos to Toeza, the conveners of this, and I think that we need more of these forums. One of the things that is happening, and this is a suggestion, is a lot of these conversations are happening in silos. So as you're saying, I've had a lot of where was public participation, what was happening. I can assure you if the president's team, the technical advisors came here and then they would tell you public participation happened everywhere. But the siloing of this process is contributing to the public voices not being heard. And I want to challenge Twaweza and other like-minded institutions that find a way to bring many more different voices to talk to the public. Because there's a lot of happening in other fields that the public is not aware of. So increase this synergy, let's get more voices. Second suggestion is, I am not leaning towards the repeal faction. There are those who are saying let's repeal this. I suggest that we should now start thinking about amending this bill. And I think that a forum like this now, what you need to do is create a technical working group, bring in people who know what really the problems are, and we will tell you, me and my professional colleagues, Mheshimiwa and others, we will be able to tell you where which sections can be amended, what we call low-hanging fruits that can be snatched very quickly before the detrimental effects take place. So right now, my challenge is start thinking about amending this bill and what is it that we can push through Parliament to create quick amendments. Thirdly, this is just general. What can we do as people? Vote better, you know. I cannot overemphasize this because in my position as chairperson for rural and urban private hospitals, I have had occasion to join Mheshimiwa and others in Parliament many times before the Parliamentary Health Committee and the Senate Health Committee. And I don't know what Mheshimiwa feels like because he's a four-term MP. But my own sense is that the quality of legislators we have in Parliament has been going down over the years. That's just my own sense. I feel that, and I was before the Parliamentary Health Committee, and it seems that the freshest people, the ones with the least experience, are the ones who end up on all health committees. So you go to a health committee, before the Parliamentary Health Committee, the quorum is less than 50%. The guys who are there are not elected like Mheshimiwa, they are nominated, and that is basically both Senate and Parliament. There is lack of seriousness in our two assemblies as far as healthcare matters are concerned. And I think that information needs to go out, that we cannot have the health committees being the last committees to be populated by those MPs who have no say, and the nominated ones. So when you go there, they don't litigate issues. So please, 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 fellow citizens, we need to make better electoral choices. And I think there is an opportunity for us, by initiating the amendment process, to start lobbying Parliament and Senate so that we get the changes. The other thing, and I feel for Mheshimiwa, is the tyranny of numbers is real. So what I see happening there is, and you people are asking, how did these bills pass? Can I tell you, even the Wabunge don't know what was in those bills. You know, essentially leader of majority is given instructions, iyo kitu ipite. And then what does he do? They whip all the members, tell them, this one is from the Mount Sinai, it must pass. So they just come, do a roll call, the numbers work, the law passes. So we are in a difficult situation, and it is good for lobby groups and, you know, civil society organizations to actually understand that our parliament is weaker than it has ever been, and they need to invest in actually supporting parliamentarians to understand that they owe the duty to the people and not to whoever is passing instructions from somewhere. So this will be my final comments on this. In terms of where we go from July, I can tell you that just be prepared. The 2.75% is coming. That one is happening. I am happy about it for this reason. I think that there are going to be so many failures the next 2 years, we will have to amend this law. So I'm not really worried, because the way I have seen the structuring around it, the preparation around it, it is going to stumble all over itself. The amendments will come from the people. People will push for changes. So I'm very optimistic. Thank you, guys.
Thank you. Firstly, any bill passed can be amended. There is also a very strict rule that it can be reviewed in totality, not repealed, reviewed. Amendment can lead to repeal. An amendment can cover in the issue of repeal. What we have in the law is the policy, the intention of the executive, the intention of which has been passed through the ministry executive to the health committee and the members of parliament, is an intentional of policy. That is then followed up by the executive to come up with implementation rules. Some of the things that you've been told here are part of implementation, which can be questioned at any time. Is the implementation in line with the vision? Was it envisaged that this SHIF would be treated like a tax payable by everybody? Those are the sort of things we need. Was it envisaged that it will only go into the consolidated fund, or that's because the public finance management bill says so? Can we amend the public finance management bill to make sure that the money that is collected goes into a ring fence? Can we then give power of authority to the Kenya Revenue Authority, who inevitably is going to collect this money, to collect this money, take the percentage of collection, and put the rest in the account? Those are the issues that we need to work on. Can we reduce the influence of Mafia House on the issue of SHIF? Those are the issues that we can still work with. I represent the African parliamentarians. I wish he was here. He answered a few calls and left and made some remarks when he's left. I wanted to answer him. We as African parliamentarians against corruption have set together with civil society what is called CESPEN. CESPEN is a civil society parliamentary engagement network, where we are giving you the platform for civil society to engage with APNAC, which directly takes you into any parliamentary committee without the protocol. It's there. Our civil society is not yet of the position where they're able to educate the masses, whether it is on this bill, whether it is on the finance bill. I wish he was here. I want to tell you one thing. There is nothing you're going to do the finance bill. The reason is the finance bill, if you look at the timetable, starts with the budget policy statement, which was in October last year. And I have been pleading with civil society, that is when you need to have engagement. You cannot come now and have engagement. It won't work, because the BPS was passed, and the budget is based upon the budget policy statement that was passed. How are we going to put it into effect? That also dictates how much we are going to borrow. Where we are borrowing from is a different issue. So the point is, this is a good interaction. This assessment is good, but it is nearly 2 years late. Yeah, it's 2 years late. However, let's not go to the negative. Let's see what we can do about it. What we need is a petition from the public. Give me 20 or 30 petitions, the 30 petitioners, and I as a private member can raise and bring that issue into Parliament to be discussed as a petition. Thereafter, if the petition is passed and we've discussed it, then it can be sent to the committee to open up the bill to see whether there is something and give us amendments, proposals of amendments. That is where the lobby comes in, and we can do it at this time. Let's not just stuck here and say, tumekwama nai, and it's going to fail. Yes, it's going to fail. Yeah? There is no doubt this thing is going to fail as the way it is planned. But, unfortunately, NHIF have got no say in this issue. And NHIF is not the only player in the issue of health for all. The player is the devolved government of Kisumu City, or Kisumu County is one, and the national government here. And you tell us where we got MPs from. Do you know, you voted for the numbers. You guys did. You voted for Hustler. You voted for Wheelbarrow. Sisi tumekwama pale. I'm an independent member of parliament. How many independent members of parliament are there in Kenya? Effectively 1. There were 12. 10 were taken by KK. 1 was taken by ODM. So there's 1 left. But that 1 can make a difference. And you can make a difference. And we can still talk to opposition and say, listen, we want to do this. To raise this issue and continue raising this issue. Sometimes, like the other day, Kimani Ichung'wah nearly wanted to fight with me. Because there were 3 of members in parliament. And we were reading a bill. I said, there's no quorum. They said, no quorum. It is no quorum. You cannot pass with 3 bills. You need a minimum of 10%. There's no quorum. So for those bills that are being passed, unless somebody raises there's no quorum, you can't go to court. So I raised no quorum. When I raised no quorum, the speaker has no option but to call it for another day. So these are the situations. I'm sitting over here today, and I will be taking it to the committee, and I'll take it to the CS, where I gave my own personal opinions to the CS is a matter of the issue of the strike. I think we have come to a situation where we must make a difference. This, you're funded by, I don't know who, but shout ya wananchi machelewa jamani. But it's still very important, still very important. I've taken 2 copies, one I'm going to raise as a result of this particular intervention and conversation. And I've asked my friend Daktari, Patia, send to me your opinions, send to me the decision make. Can we decide today, at this meeting, that this thing does not meet the criteria of which wananchi will benefit, and that we are going to form together and send a petition. And I'm saying to you, what is within my right? Send me a petition. I have the authority to receive a petition. And I have the authority to raise it to the parliament. Whether the speaker allows it or not, that's a different issue. But send the petition under the petitions bill. We have a voice. Send the petition. Don't come and throw vegetables outside our place. It doesn't make sense. Don't come and bring pig's blood there. It doesn't make sense. Follow the right way. Make the petitions. Even make 100 petitions There's a law. The petition must be heard and must be valid. Matata is there, other people are there. Yeah? Have a heart. And I'm telling you one thing. I want you to tell him, whoever says, you, Dr. There's some very intelligent people on the health committee. Dr. Nyakal, former PS and former director of health. The chairman is another doctor. The Pokose, there are about 4, 5, 6, 8 doctors on that. They're there. Yeah? Many issues are raised, but numbers nashindwa. And then they have not, some of them do not have. I asked Dr. Nakal, have the guts to put what is called a minority opinion. How is he? The committee I'm sitting on, come and see the number of minority opinions we've put. Even if it's myself, I'll just put a minority opinion. Sitaki, it's not right. It comes to parliament, it's there. Do you understand me? CESPEN, utilize CESPEN. Your civil society, utilize it. I have our head of secretariat here, Jadaida Apnak. Use us. Use us. We can make a difference. Maybe a very small one, but we can. Thank you.
I think that's a very, very positive way to end it, right? We might have missed many, many opportunities, right? But it's not it for us. We still have an opportunity to influence the implementation, right? So after many, many, many coming to an end, we have finally come to an end. But before we do that, allow us to give a better round of applause to our speakers today. We'll do the old-time factorial. Okay.
Now, I want to reinstate, just impress on you. On the 1st of May, I wrote to this, you can confirm that this is Elijah, CEO, National Health Insurance. Please call me urgently on NHIF. My CDF and me have sponsored 2,000 members whose insurance cover is expired on March 2024. We have paid for the renewal of some of them, but are getting confusing signals on SHIF, NHIF transition. Yeah? And then we spoke, and I wrote him a letter. May 1st. Then I wrote him a letter within about a week of that. Now, my dear friends, if NHIF CEO cannot tell me that we want to send him something like 15 million, 13 point something million shillings, yeah? And he cannot make a decision, where are we going? And my brother, let me tell you one thing, you're too late for the Finance Act. Also, and you have never thought about, you have no idea what you're talking about, because the Finance Act starts on the budget policy statement, which was October. So you have to, you yourself, as you are now talking as informed people, must start in next October, before next October. We start in January. So by the time we get to the public health budget policy statement, you have been able to make that. We have talked about CESPEN. I just thought you had left us. I'll come back to that. But this letter, as I said, just believe me, now if they can't answer this, what are they going to answer all the questions that you've given them? All the questions. We're offering them nearly 15 million shillings and telling us, can you tell us what to put it, SHIF or NHIF? And when we put it there, wherever you tell us, if you put it in NHIF, we'll get the services in SHIF. As Dr. Ari has told you, NHIF is dead, and they are going to go pending bills. So my 15 million shillings goes to pending bills, not mine. Wananchi, Kisumu East, goes to pending bills, and then we are not covered. No way. Do you understand me? Thank you.
Yeah, let's hope they did. Thank you so much, Mheshimiwa and Dr. Ari. Could you please do the all-time factorial 5, 4, 3, 2, 1 for our panelists? I think they provided such great insights. Many of us leave here educated, Sindeo. Many of us leave here more informed and, of course, challenged. Members of Transform Health, I think, will be coming to you. There's a lot that's coming out of this discussion, and you are the experts on this issue. So we are compiling a report that they will share with all of us in this room, and that also includes some of the resolutions that we have concluded here and that we can start acting on. And hopefully the members of Transform Health, you can take us on, given that you're the experts in this sector. But of course, we have the support of both Daktari and Mheshimiwa to actualize these things. Now, let's do the all-time factorial. We'll start with 5, 4, 3, 2, 1. All right? Shall we start? 1, 2, 3, 4, 5. That was for Daktari. Let's do for Mheshimiwa, okay? Same way, please. 1, 2, 3, 4, 5. All right, and then Daniel from NHIF in absentia. It's very important. That was also very critical for us to know. So 5 factorials for Daniel. 1, 2, 3, 4, 5. Right, thank you so much. And for yourselves, if I started mentioning each and every one of you by names or even by the organizations you represent, we'd spend another 1 hour. So allow me not to do that, but to appreciate you for taking time, replying to our emails, spending time from 8 a.m. to 2 p.m. We don't take that for granted. And this is our conversation. It's not just a Taweza conversation. Ours is to bring you the voices, and those of us experts in the health sector will help us take this conversation. But we're interested in taking this conversation. So we'll be reaching out to partners within these circles to help advance this conversation. But for you, for coming, for paying attention, asking questions, suggestions, that's very appreciated. So let's appreciate you for coming with 5 factorials. Same way. 1, 2, 3, 4, 5. All right. And to appreciate you even more, we have a bit of lunch. Lunch is prepared for you. My colleague, Wandia. Wandia, where are you? Mary Wandia? Okay, as we look for Wandia, this conversation is happening online. Still, please continue engaging. And Taweza has done a survey on finance bill. Please look out for that link. It's online on our Twitter X handle now at Taweza_KE. Look out for that, and please feel free to spread it as much as possible. It's all right, Mheshimiwa, we will. Now, to you, Wandia, please raise up your hand. Wandia is a colleague. She is the one who holds your key to lunch. So please see her and smile to her nicely. She will give you a lunch voucher. And for those of us online, we also appreciate you, but unfortunately, we won't be having lunch for you. We'll have lunch for you next time when you come into the room. Sandia, the lady in a cream top, and then here will be Philbert, my colleague. If you have not registered, we would really love to keep your details so that we share this information and we tell you how we move forward from here. Please see Philbert, the gentleman walking to the front, and please make sure you register. We have come to the end of today's conversation, but let's have these conversations more. If you host a session like this, please reach out to us and we can help to spread information and also invite us to your sessions once again so that we keep having this conversation. It's critical. Health is not just for NHIF or for the Ministry of Health, it is for us. And so we need to continue having this conversation. Is that correct? Now I'm wishing you a lovely afternoon. Say hi to a friend, take a picture with a friend, and tag us online. Thank you so much and have a good one. To our panelists, once again, let's escort them with claps. They'll be the first ones to take. Wandia? Yes. If you want to take pictures with this distinguished experts, they are free and you can do that. And then Wandia will keep lunch vouchers for the 2. All right. Thank you so much, people. Have a